Operations Committee. So thank you for coming on time. As you know, we try to start as on time as we are able to. And I thank you for making every effort to be on time. I appreciate it. Before we get into today's hearings, I want to remind the members of the committee to please check the meetings page on the Maryland General Assembly for the meetings. Please check your emails for schedule updates. You guys get the emails every single day, the day before. Also, you know, when the subcommittees meet, I know some of the staff members call a couple times to ask. Please remind them to check their emails because we send you the, actually today's council is Erin Hopwood. And every council sends you the agenda for the subcommittee. They send you the time you're going to meet. And then, so please also pay attention to the floor at the end of session. They always announce when we have the committee hearings and when we have session and when we have subcommittee as well. Okay. So that Michelle doesn't get so many calls. I really appreciate it. So good afternoon and welcome to the bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick. My vice chair will be joining us shortly. You'll see that there's some members that are not here. They have hearings in other committees. So they'll be coming in and out, but that does not mean they were not paying attention. They also have access to the YouTube channel for what they missed. So know that we pay attention, and that also the bills are assigned to the subcommittees where we have a very robust discussion, as you know. I kindly ask for your patience if we encounter any technical or streaming issues. It does happen, not often, but please be patient. Please set your electronic devices. I'm about to do that, so I'm not embarrassed to vibrate. If you have to have a conversation, please step out of the committee. As a reminder, there's no food or drinks allowed in the gallery. That's because staff then has to clean it. You'll see us with drinks. That's because we sit here for many hours and we have to keep hydrated. Otherwise, you come the next day and you have no delegates to pay attention to your bills because we will be sick. For each bill, I'm going to tell you how it's going to work in this committee. We are going to hear from the bill sponsor, and in this committee, we do not time the bill sponsor. However, I do ask you respectfully to be kind and generous and don't abuse it, because otherwise I have to step in. The other witnesses will get 2 minutes, and there's a timer on the left that tells you, so please watch it and start wrapping up. Though it will go in this manner: favorable with amendment, and unfavorable of a panel that is supporting, then a panel that is not in support, in opposition, they go next. And it's the same thing for the virtual witnesses: favorable with amendment, and unfavorable. We start first with the people that are here, and then we do the virtual witnesses. Please adhere to our committee. I know you're doing it and I appreciate it. Now and then we have a little flexibility to your, one question, the rule of one question and one answer, and please keep your questions brief. Members of the public, you'll be able to watch these proceedings live stream on the Maryland General Assembly website and on the YouTube channel. So today the bill hearings will be in the following order. 1 second. I got it right here. Thank you, Erin. I appreciate you. And I want to thank staff for your hard work. And we do have a visitor today. Can you please get up and tell us your name?
Hi, my name is Sharonda Huffman, and I'm with Emerge.
All right, wonderful. And she is shadowing. Yeah, who is it? Okay, wonderful. Welcome to the committee. We appreciate it. So the bill hearing, the order is the following: House Bill 119, followed by 230, 149, 153, 461, 353, 51, 177, 96, and the last bill of the day will be House Bill 97. But also keep in mind that I may change it if the committee sponsor is in another bill hearing. I have to make adjustments, or if a witness is not here yet. So why don't we get House Bill 119, which is the department bill, Public Health, Giving Infants a Future Without Transmission Gift Act. Will you please come with your panel? And if you can tell us your name, and we know you already, but
That's okay.
the world out there does not know you, so go ahead.
Thank you. Good afternoon, Honorable Chair Peña-Melnick and members of the Health and Government Operations Committee. My name's Peter DiMartino, and I currently serve as the Director of the Infectious Disease Prevention and Health Services Bureau at the Maryland Department of Health. Thank you for the opportunity to speak to HB 119, which addresses the devastating impacts of perinatal HIV transmissions and congenital syphilis in Maryland. The rise in congenital syphilis cases is deeply concerning. Nationally, there has been a staggering 937% increase in reported congenital syphilis cases over the past decade. Maryland has seen nearly a 300% increase. Specifically, in 2022, Maryland reported 46 confirmed cases of congenital syphilis, a 55% rise since 2018. This trend underscores the urgency of the situation. Also in Maryland, the incidence of perinatal HIV has seen a concerning rise. Over the past decade, 18 infants have been diagnosed with perinatal HIV, and a third of these cases emerging in just the last 2 years. Perinatal HIV and congenital syphilis are preventable consequences of no prenatal care, inadequate prenatal testing, and late treatment. Perinatal HIV can cause lifelong immune deficiency and life-threatening infections. Congenital syphilis can cause infant death or severe complications, including blindness, deafness, and developmental disabilities. HB 119 amends prenatal HIV and syphilis testing requirements and HIV reporting requirements. Requiring universal syphilis and HIV testing at the time of delivery ensures equal access to testing for all women at delivery and equal access to immediate evaluation and treatment for all infants. HB 119 will have a short-term fiscal impact that will likely be offset by long-term cost savings of the lifetime costs of caring for children diagnosed with either syphilis or HIV. The cost of syphilis testing is approximately $30, while the cost of treating an infant with congenital syphilis is more than $1.1 million for just the first 2 years of life. The average cost per HIV test is $24, while the lifetime cost of care for an infant with HIV could be well over $1 million, according to national analysis. In recognition of the profound potential the bill has to protect infants in Maryland, the department strongly supports HB 119 and urges a favorable report on the bill.
Thank you, and thank you for bringing this wonderful bill. I was looking at the fiscal note, and I noticed that it's substantial, but most of it is being paid by the federal government. Our portion is very small in comparison, 15%. So just for the record, and we'll talk to the leadership to make sure this is okay for this year. So staff will give you a call, just to let you know. I would like to open it up for questions now for this witness, and then we have another witness that we'll be calling. So are there any questions for this witness on this bill? All right. Delegate Hill.
Thank you, Madam Chair. The Women's Law Center had an amendment that they proposed. They had some issues. Have you seen those?
I have.
And is there any problem with accepting those amendments, which would be changing the language from saying the body of a woman, perhaps to saying pregnant, the person during delivery and using person?
I believe we're open to working with stakeholders always. So yes, we can work.
All right, thank you.
And I don't see any other questions. So the bill will go to subcommittee. So I asked you to come to the subcommittee and they will be considering that language, okay? Thank you so much for all your work. We really appreciate you.
Thank you.
You're welcome. Next, we have Pam Casemeyer.
Hello, Madam Chair, members of the
Good
committee.
afternoon.
This is Pam Casemeyer, and I'm here on behalf of the American College of Obstetricians and Gynecologists, the Academy of Pediatrics, and MedChi, here strongly in support of the department's legislation to enhance this testing. As you heard from the department, there has been a significant increase in HIV in pregnant women and infants. It's kind of overwhelming and astounding. So the members, our clients were very happy to take on doing additional screening and testing and the other requirements that are reflected in this bill, because we do think it's an issue that we're going to need to address, or it's only going to continue to escalate. Furthermore, the changes in the language, which is somewhat unusual for the physician community, change it to from physician to healthcare provider who is caring for the woman at delivery. And as you know, there's certified nurse midwives and certified midwives and even direct entry midwives. So this now would enable all professionals who are dealing with pregnant women and deliveries and infants to have to do this screening and testing, which should further increase our awareness of where it's occurring and why. So with that, we would request a favorable report.
And thank you so much for your work. Are there any questions for this witness? Seeing none, we really appreciate your expertise and your testimony today. Our last witness for this bill is Camila Reynolds Dominguez. Is Ms. Camila Reynolds Dominguez from Free State Justice here? I don't see the person, so this will conclude the bill hearing on House Bill 119. Members, we're gonna move on to House Bill 230, and it's Motor Vehicle Administration death certificates issuance of copies. Will you bring your panel up, please? Thank you. Good afternoon. How are you?
Good afternoon, Madam Chair, members of the committee. For the record, my name is Chrissy Nizer. I'm the administrator of the Maryland Motor Vehicle Administration here in support of House Bill 230. House Bill 230 would allow the MVA to issue an official death certificate copy for customers who require documentations to complete certain transactions. This bill's sole focus is really about enabling a better customer experience, especially if you think about it. When someone has lost a loved one, it's coming to the MVA to be able to get that new title. The last thing they need to do is leave and go get that death certificate and come back. So it really is about being compassionate with that customer in that moment to enable them to complete their MVA transaction. Under Maryland law, as you're probably aware, any applicant who's attempting to change that vehicle title has to present that death certificate. It's a ownership document, and so that's part of the process. Currently, MVA for the last several years has been printing birth certificates for our customers who are in situations where they're trying to get that ID card or their driver's license and they don't have that document with them. They were born in Maryland. We have the ability to access the vital records information and be able to issue that birth certificate. It's important because we can issue it without charging any additional fee. They leave with that birth certificate. In this case, they'll leave with the death certificate for use for whatever other purpose they might need. But it would give MVA the authority to access the Department of Health's databases and produce the necessary death certificate. It would be done in the exact same way that it would happen at the local health office or through the Maryland Department of Health. I want to state that just with the birth certificate process, we follow the exact same security and auditing processes. We not only audit ourselves, but the Department of Health also audits us as well. Since we enacted the birth certificate legislation back in 2018, more than 4,000 customers have been able to utilize that service for issuing the birth certificate and then going on to get that ID card or driver's license. So it's a lot of saved trips for customers, and then they have that birth certificate to use for other purposes. We believe the same benefit would result from the death certificate authority in this case. We know that MBA processes more than 26,000 title transfers. We don't know how many of those customers had to reschedule appointments because they didn't have all the documentation, but I can tell you it is a frequent story that I hear, especially when somebody has passed away and there's a lot of strain and stress on that individual. It takes us one more step forward in terms of our one-stop shop approach at MBA. We're really trying to look at what the customer needs and figure out how we can help them most efficiently. And with that, I would ask the committee to have a favorable report. Happy to answer any questions.
You're gonna be lucky if you don't get a move favorable from someone.
I'll take it.
Are there any questions from anyone? Seeing none, look, this is an easy bill. It's the right thing to do. Thank you for doing it. And
Thank
it will go probably straight to the committee for vote, okay?
Thank you so much.
Thank you so much. And one of my colleagues sent me that message. I think she was absolutely right. And I believe that actually this is this concludes the bill hearing on House Bill 230. And I want to thank you for meeting with the committee and for being available. Thank you so much. This concludes the bill hearing on House Bill 230. Members, we're gonna go next to House Bill 149, Delegate Pippi and Kerr. Good afternoon. How are you, Delegate? And will you be so kind and bring a panel if you have it? Thank you. And you can get started. Thank you.
All right. Thank you, Madam Chairwoman and esteemed committee members. Delegate Pippi here on behalf of HB 149. This bill deals with medical records and the storage of such. And here's what we're trying to do. So Maryland is currently tied for having the most generous medical record keeping in the United States. Matter of fact, some would say that we're not even compliant with HIPAA, which requires 6 years of storage, whereas Maryland law can allow you to get rid of records after 5 years. This has become quite problematic. Some of you may have been aware that there was a doctor in Frederick County that was arrested in 2019 for sexually abusing children. What they found out was that he had been abusing children for 40 years. And furthermore, individuals that read about it in the paper, had the courage to finally come forward, went to retrieve their medical records and they were all destroyed. Because current Maryland law allows a medical provider to destroy records without the consent of the patient. So again, think about that loophole for a second. To add insult to injury, this pediatrician was actually my kid's pediatrician. Now, I was fortunate to have never had an issue with my children, but just imagine all of the children that were impacted, mostly in the Hispanic community. His name was Dr. Ernesto Cesar Torres, and a lot of these children never came forward. So it's very problematic. So what our bill does, it simply extends the time that a provider would have to keep records. Again, most of these records now are digital. I mean, keeping a digital record, how hard is that? But it also gives them an ability to send out notice to a patient to say, hey, we'd like to get rid of these records, and the patient has the ability to consent to that or at least go and get a copy of it for their own records. I think this is a good decision. When you compare us to other states, you will see we are the worst at keeping medical records. We are the worst. We may not even be compliant with federal law, and I think this is a good thing. The last thing I'm going to say is, do you remember Larry Nassar, the doctor who was sexually abusing Olympic athletes? Well, let me tell you, Michigan in 2023 changed their state law to address these sorts of issues. So I think this is something that Maryland can lead on. We can do it without overburdening our medical providers, the overwhelming majority of which are in compliance and do good things. But this is something that needs to happen. This is something that we need to address. So, Madam Chair, thank you very much.
Thank you. Next, please.
Good afternoon, Madam Chair, Madam Vice Chair. My name is Patrick Gilbert. I'm a Senior Assistant State's Attorney in Wycomico County, and I'm here on behalf of the Maryland State's Attorneys Association to urge a favorable report on House Bill 149. Sharing with someone else that you've been the victim of sexual abuse takes an incredible amount of courage, almost unfathomable amount of courage. particularly when the perpetrator is a relative or a loved one. And when a victim finds that courage and comes forward, sometimes years down the line, medical records can provide critical corroborative proof and will often make the difference when it comes to holding perpetrators accountable in both the criminal and the civil legal systems. The information contained in medical records, whether directly discussing the sexual abuse or documenting its tragic consequences, things like late-age bedwetting, self-harm, depression, substance abuse, and suicidal ideation, can tip the scales in favor of justice at trial. House Bill 149 provides for a modest extension in the period for which medical records are required to be retained. And in an age where record retention often means ones and zeros on a server in Verona, Wisconsin, and not physical space in expensive commercial real estate downtown, there's no reason why the cost to providers associated with this bill should outweigh the benefit to survivors of sexual abuse. Thank you for your time, and I yield to the committee's questions.
Thank you. Are there any questions for this panel? Yes, Delegate Johnson. And I'm sorry, it was Delegate Kaiser and then Johnson.
Thank
We
you,
are very polite here.
thank you, Madam Chair. Delegate Pippi, sounds like a great bill. I had a question about just one part of something you said, that someone could request the records. In that case, are you saying both paper and electronically? Would it have to be for free? Have you thought through those details as well?
Sure. So we've heard some feedback from some of the folks that have some questions, concerns. I mean, we're open. As mentioned, most medical providers now have digitized these records, which would be very easy. In the case where there are still paper records, we're open to the will of the committee. If there is a way that is workable for these providers, whether they could have them stored at a separate location. So, for example, someone asked, do I have to keep them stored at my office for an indefinite amount of time? We would be willing to put something in there where they could store it off-site somewhere else, as long as it was accessible to the patient, if that answers it.
It wasn't about, no, my question wasn't about the storage. It was about when someone asks to get their records.
Oh,
Can they
okay.
get it both electronically or paper, or what, or would there be a fee involved? If it was paper copies or anything else?
Those are excellent questions. I don't know if I have the answer to that. I would imagine that somebody could provide a copy of records. I would imagine, hopefully they wouldn't require a fee, but if that needs to be adjusted or addressed in committee, I'd be open for that. That makes sense.
Thank you. Delegate Johnson, followed by Delegate Hill.
Thank you, Madam Chair, and thank you,
You're welcome.
Delegate, for bringing the bill. I don't know if you saw the Department of Health, the letter of concern. And do you think that this bill would address that concern about giving the patient 30 days notice to get a copy of the record? And also on the physical summary for small business effect, it says potentially meaningful. Can you explain to us why that would be meaningful?
Well, I think if you looked at the fiscal note, it talks about any expenses related to the storing of records. And as the gentleman to my right mentioned, I mean, what is the true cost of maintaining a digital record these days? I mean, what is that real cost? I can't imagine it being significant. I mean, we'll hear I'm sure some folks behind me that may say something different, but I think that's what they're referring to is just, I mean, again, you're required now to store records. What we're saying is we just want you to store them a little longer. I mean, that is the difference. And there's something I didn't mention, and I apologize, not a second bite at the apple, but this body unanimously passed the Child Victim Act of 2023, which gave people an opportunity to look back for these cases, child abuse. They look back, the records are gone. I mean, that's what we're trying to address here is that we passed as a body a law that gives child victims the ability as adults to look back into this abuse, and then they go looking and the records are gone. You know, so that's what we're trying to adjust.
One
You
follow-up.
can have another one.
Thank you, Madam Chair.
Mhm.
So with the laws that we have now, if we just required a 30-day notice, that if anyone wanted to get copies of the records, would that suffice? I mean, instead of extending the length of time that we need to hold records?
Sure. So I think the difference is now they're only required to send out a notice, but they're not required, I mean, to the last known address. So you send out a notice to the last known address, there may not be anyone there. With this bill change, someone has to affirmatively say yes or no, or the time is just extended. So there's just two options really. The time is extended or you actually have to have someone say, no, I would like to actually get a copy of my records before you destroy them. Whereas current law doesn't require that at all. I think current law, you just have to, there's a time frame, and or you can expedite that time frame by just sending out a notice to the last known address. Well, people move. I mean, how many people in this room have moved in 2 or 3 years? I mean, it's just not sufficient. It's not adequate. It doesn't do any justice to somebody who would like to get these records related to child abuse. So the 30 days, I think to your specific question, is that adequate? I don't think that's the big part of it. That still could be adequate. But the bigger thing is the time frame, and then getting the affirmation from the person to actually whether you can destroy the records or not. Yeah.
Delegate Hill.
Thank you. I just want to get some clarity, Delegate Pippi, and thank you for this bill. So I think some things got confused. You said that we only require it for up to 5 years, but in a minor, it's through the age of majority plus 5, right? So a minor, it's not an 8-year-old's records would be destroyed after 5 years. It would be age 18 plus 5.
Plus 3. So it's plus 3 or 5 if they're 17. So I think the best case scenario for a minor is age 22 currently.
Where it says plus 3 years or for 5 years after the record report is made.
Right.
This, okay.
Yeah. So if they're a minor, they're under 18, right? So let's say they're 17 and 364 days old. They could have until they were 22 and 364 days. So age 22 would be the absolute max that a current provider today would have to comply with the law.
Right. And so under this, they'd have to keep it for 10. So like my ophthalmologist just retired.
Yeah.
And we got a notice that he was going to retire in a few months.
Right.
We're welcome to get our medical records. And then after a certain time, got a notice because I'm at the same address saying, I've handed it over to another doctor. I'm retiring.
Yep.
If you want it, she's agreed to be the custodian, which she had no obligation to do.
Yep.
I've contacted her office twice in the last 2 years to get a copy of the records. And what they're saying is it's too hard for them to pull them back up to actually give me a copy of the records. I can't hold her at fault. I wouldn't want to hold him at fault. I was given a chance to get the records. So I'm not clear how that would work. I would also, I don't know if you have numbers. You said most records are digital now. I'm not sure how far, I mean, I've got thousands of records that aren't digital, and I'm sure there are people who have many more patients than I've had. So can you help us understand what your thought is in that kind of situation?
Yeah, so
what does that mean?
So as you know, as a medical provider yourself, so currently to comply with the law, you're required to keep medical records for a certain amount of time. So this bill doesn't change that. It just requires that time to be extended. Or if you would like to, let's say, get rid of records sooner because a colleague retires, you merely would send out a notice and then the patients would have to affirmatively say, yes, you have my permission to go ahead and get rid of my records. So that's the only thing that my bill does. Furthermore, on your question about what is the percentage of these providers that are doing digital stuff. So I've had obviously a lot of phone calls about this bill from the medical community. And my assertion from those conversations is that the majority of medical providers have digitalized their stuff. You're going to hear something from MedChi and some other folks here in a minute. But that is the trend. But we are open, 100% open to the will of the committee on what to do with folks that maybe like yourself are still in the paper format of records. We're open because what we want to do is we want to solve this issue. We don't want to burden medical providers. We don't want to make your lives miserable. What we want to do is give these victims of, in most cases, sexual abuse an opportunity to get justice. So that's what we're looking at.
Thank you.
I don't see any other questions. Delegate, I'm going to give you homework. As you know, the committee has a lot of work. I need you to meet with MedChi. And who else do you think? The Board of Pharmacy. And let's see, they were unfavorable, MedChi favorable with amendment, and with the Maryland State Dental Association. If you can look at, the committee sent you the witness list.
Yeah.
Look at the witness list for people that have favorable with amendment and unfavorable. Please, actually, you guys are here right now. Before he leaves, I want you to go outside and take your calendars out and agree on a date to meet and work it out. As soon as you work it out, we bring it to the subcommittee, okay?
You got it. Thank you.
Thank you very
right.
much. And so wait for them to finish.
I will.
Thank you so much.
Thank you, Madam Chair.
So next we have, is there a Ronald Jara show? Hi, how are you? How you doing, sir? And I apologize, I should have called you. You were part of that panel as well. Well, now you get all of us to look at you by yourself.
That's good. My name is Ronald Jericho. I'm testifying on behalf of the Maryland Association for Justice. Some of you know that I was a judge in Anne Arundel County in 2010 and returned to practice in 2011. We have a slightly broader view than just sexual harassment cases or sexual attack cases. This actually promotes good medical care from our view, transparency, and litigation benefits. It promotes good medical care because quite often when somebody comes in, like I had tongue surgery for cancer, and they had to go back 8 years in my medical records to get my medical history to see what it was and how it progressed. It adds to transparency because then someone can look at the past medical history. And in litigation, there are certain categories of cases, even routine personal injury cases, where the long medical history of somebody is relevant. So in a workers' compensation case, you can reopen that case for lifetime, and that medical history may become relevant later on down the road. So extending the time from 5 years to 10 years makes tremendous sense. In many personal injury cases, even the defense contends that the person's current condition was caused by a pre-existing condition. And you need to go back and get all the medical history to show whether that's accurate or not accurate. In Social Security cases, which you'll hear about in the next bill, you need to get the full lifetime history of somebody to justify Social Security. So we are asking for a favorable report. And in answer to one of the questions from the panel, the current cost of medical records retrieval is capped in Maryland under Maryland Healthcare Act 4-304, and that's the subject of the next hearing you have, and under a federal law called the High-Tech Act, so the patient is able to retrieve their records at a nominal cost as defined, usually about $25 or so. And so that's in answer to that. And one of the answers there is that in the bill itself, it talks about once the notice is given and if the patient authorizes, the healthcare provider has to hold it for 60 days for the patient to retrieve their records. Thank you. So the MHA asked for a favorable report.
Thank you, sir, and thank you for sharing your experience. Are there any questions for this gentleman? Delegate Hill.
So I get I think, the idea of extending the period longer. I'm not clear about, other than being problematic for the provider, what the portion of the bill that asks for an affirmative consent for the record to be destroyed is all about. So can you tell me why that is of significance rather than just say you have to keep it for longer?
Yes, as I heard the testimony before, it sounds like a patient can authorize an earlier destruction than the statutory time period. That's the way it sounded to me. I'm not familiar with why that's in there, but it sounds like a healthcare provider could. And then it says that the healthcare provider has to hold those records for 60 days up until the date of destruction in order to permit the patient to retrieve their records.
Mm-hmm. Okay. Any other questions? Seeing none, thank you so much, sir, for your testimony today. And we have our last witness for this bill, favorable with amendment, Mr. Steve Weiss. Yeah, Dr. Gilbert was the one sitting next to him. Good afternoon. How are you?
I'm very good. How are you?
Good. So tell me how you're gonna fix this.
I'll get there.
Okay.
Steve Wise on behalf of MedChi, the State Medical Society. Obviously, the set of events that Delegate Pippi described is very concerning. But we want to make sure that the remedy that you adopt here is really effective at solving that issue. Our principal concern with the bill is the authorization requirement that it sets up. So under current law, you send out a notice and you say, your records are going to be destroyed. Here's an opportunity to come and get them. Under the bill, you would send out that notice, but you couldn't take action until you got a written authorization back from the patient. I think that process sounds nice, but it's extremely unwieldy for a practice with hundreds or thousands of patients. You're going to have out-of-date addresses. You're going to have name changes. That being said, the notice provision in the law right now is so old, it talks about publishing it in a newspaper of general circulation for 2 weeks. I mean, just putting in email might be an improvement over the current law. So that's something we could look at on the notice piece. The deadlines, agreed. The 5 years in Maryland law, it violates the Medicare law, which is 7. So that's, I think, a pretty straightforward change that I've talked to the sponsors about. So maybe we could go to 7 with adults. The minor change, it proposes to go 18 plus 10 years. If you're actually holding on to those records and you go out of practice when a child is 5, that's 23 years of paying for storage for those records. And I'm not talking about physical storage. It could be electronic storage, which still costs money. But even so, now as a practical matter, I think pediatricians have said, they're keeping the records for a longer period of time anyway. We need to find the right balance for that.
You take a few minutes because you're
Okay.
gonna fix it, so go ahead.
Yes, and
Save
here's
the
my,
subcommittee time.
here is my, my final piece of the discussion that we had at MedChi, which is the state has an interest in having a repository for medical records of some sort because things happen. Doctors die unexpectedly. They go out of practice and nobody buys the practice. There's supposed to be a nice, again, orderly process where somebody comes in and cleans all of that up. It's not quite that easy in real life, and maybe CRISP or some other database that the state has. I know this is not free and there would be a fiscal note, and I'm not trying to saddle Delegate Pippy's bill with that, but as food for thought for this committee, that is a long-term remedy for this situation.
That's probably a bill for another year.
Correct. But
Uh-huh.
I thought it was worth sharing.
Yeah. I appreciate your thoughts, but I think that what I would like you to focus on with the sponsor of the bill is on the timing, right?
Right.
Whether it's an adult and a child, making sure that we comply and maybe mirroring the Medicare rules.
Mhm.
And then requiring the storage, right? Because people have to pay them anyway. I don't think the state should get at this point, given our fiscal situation,
Right,
and to
understood.
help into people's private practices and storage, right? So if you could make yourself available, and I know you're really good at doing that. Your shop is excellent at doing that with a
Thank you.
lot of these very difficult bills. If you could do that, that would be great. I see that Delegate Riley has a question.
Thank you, Madam Chair. Yeah, so I kind of heard what Delegate Pipke said, Pippy. I kind of did a combination.
Thinking about taking
Uh,
the food.
So anyway, so heard what he said is that, the majority of physicians are now moving to electronic records, which is good. So I'm familiar with most of my physicians now have like the portals, like, my account, my
Right.
doctor, whatever, there's several. Do you know by any chance how long they have to keep their records to where, they would be easily accessed within a 10-year period?
You're
or
referring to
whatever?
the records that you go online and look at.
Right.
Yeah, they would be subject to these same
These same rules.
Yeah,
So
now,
right now they're only holding them for 5 years?
yeah,
as well?
now, I don't
Okay.
know if they contractually have agreed with, I'm familiar with Athena, for example. They may have a contractual agreement where even if they went out of practice, that Athena is obligated under the contract to retain them for a longer period of time, if that makes sense, because they're a third party a lot of times.
Okay, all right. Thank you.
Yep.
Delegate Hill?
Yeah, thank you very much for your testimony, for some solutions. Do you have any idea, does Medicare have any idea, even as physicians change to digital, how many of them actually take their older records and transfer them digital, or they still have, again, I know a lot of practices who have
Mhm.
decades or even sometimes less of old records, but the cost of having those made digital, so they have both. And when a new patient or old patient comes in,
Right.
that's when they scan the old record and make it digital, but they have storage spaces and boxes of non-digital records. Do you have any sense of?
I don't. I was here when the state began to encourage electronic health records, and there were some incentives to do that offered by the insurers. But that was a big undertaking, right? To go back for everything you had as of, let's just say 2012, 15, I'm losing track of years now. But I think the more likely scenario is most practices picked up at a certain point and moved forward with electronic health records because of the cost of going back and digitizing. I mean, whatever business you may be in, members of the committee, just think of all your files or even your personal files at home. Going back and digitizing all that is quite an undertaking. So with hundreds or thousands of patients, I doubt that many of them undertook that.
All right, I see Delegate Bagnall followed by Woods.
Thank you, Madam Chair. And just on a straight reading of the bill, it appears that if a patient dies while in practice, under this bill, there would be no remedy other than waiting for the timeline to run out, because there would be no way for the patient to respond to give written authorization. Do you know if in current law there is a remedy, or is it simply waiting for the timeline after notification?
I want to make sure I understand your question. If the physician dies?
If the patient dies
Mhm.
and, under current law,
Oh.
they're notified.
I see.
There is no requirement for a response. So I don't know if there's an expedited process in statute somewhere else, or if it's simply you just wait for the timeline.
I
after
understand.
notification.
And I did not read the bill to provide a remedy when the patient does not respond.
Okay. Delegate Woods.
Thank you, Madam Chair. So my question goes back to the difficulty that has been expressed in maybe it's trying to reach patients. So in my profession, we have systems set up whereby we can do something called what we call a diligent search. So I could actually get the information, even if the person has moved to another state. Are there not systems put in place whereby with the proper identifying information, you could not locate that patient?
Yeah, there may be, Delegate Woods, and you may be more familiar with that than I am. I think
Bless you.
even with that, I mean,
Bless you.
bless
Bless you.
you.
Bless you.
There is, with a large number of patients, that would be quite a time-consuming task. And you're going to start with, I think, the information that you have, right? So a period of time is going to pass. And then, I guess you would then go through and under the bill, figure out who did not respond and have to go through those steps to try to locate those folks. A smaller practice, maybe that's doable. A large practice, I think that's going to be pretty time consuming.
Okay, any other questions? Seeing none, so if you could make yourself available in the next few minutes,
I will do
that
that.
would be great. I really would appreciate it. This was actually the last witness for this bill, so this concludes the bill hearing on House Bill 149. And Delegate Pepe, I know you're about to start a meeting. You could feel free to use my conference room if you want to. All right, wonderful. I love it. You want to take Delegate Hill with you? No, just kidding. Go ahead. Go ahead. I think that's a great idea. You hear it now, you hear it later. Go ahead. Okay. All right. Thank you, Delegate Hill, for your service. We have now House Bill 153. Delegate Rosenberg and Stein, medical records fees, attorneys representing patients. Can you please bring your panel and I'll tell you who they are. I have Scott London, Stephanie Means, Breanne Riley, Andrew Sindler, and Ronald Jarashel. And there's Wanda Clark. Are you here? If you guys can all come up, just pull some chairs over and let's do this. Good afternoon.
Thank you, Madam Chair and members of the committee. I shouldn't jinx myself and say, I hope hopefully this bill doesn't need the same ending as the last bill. It'll go directly to the
Well,
subject.
Delegate Hill won't be able to assist. She's kind of busy right now.
Thank you, Madam Chair and members of the committee. 3 years ago, this committee recognized that we should not impose a fiscal penalty, that is the cost of securing medical records on an individual who needs that information in order to obtain Social Security benefits or Social Security disability. We provided that in 3 circumstances, the individual, his or herself, that individual's representative, or someone either working or as a volunteer for a nonprofit assisting that individual in obtaining this vital information. What House Bill 153 would do is extend the current law to an attorney who is seeking this information on behalf of a client. It becomes burdensome on the attorney, and I believe you will hear testimony indicating that some attorneys won't take these cases if they have to pay the fee because of just the circumstances. So this is building on what we've done, and I think what we did 3 years ago, and the testimony will with individuals who benefited from this information, as well as from attorneys, I think will make the case for House Bill 153. So I would urge a favorable report from the committee, and thank you.
And Delegate, who would you like to go next?
Mr. London.
Mr. London, good afternoon. How are you?
Good afternoon. I'm doing great. Thank you to this committee, Delegate Rosenberg, Madam Chair. Thank you for the opportunity. I'm Scott London. I'm a lawyer. I'm the owner of London Disability, and I have dedicated my career to helping the disabled navigate the complexities of the Social Security, disability, and SSI programs. And as Delegate Rosenberg said, in 2021, this committee passed a very important bill which became law at Health General 4304C5 and recognized the importance of providing free medical records to a vulnerable class of citizens in Maryland, which is the disabled. And what I am asking this committee to consider is adding attorneys to the list of requesters. And here's what's happening in practice. When I'm representing a client, I am ordering medical records from a doctor or a hospital, and I am almost always going into a portal to upload those records. So I'm identifying my client, the correct dates of service, and the relevant time period of records that I need. I'm viewing them, I'm uploading the records, I'm transferring those records to my file server. I'm then forwarding those records electronically to the Social Security Administration. There is a lot of technology involved, and my clients simply cannot do this. They don't have a desktop, they don't know how to upload, they don't know how to download, they don't know how to securely send to the government. But here's the rub, here's the problem. The providers are sending me an invoice, which I am then passing on to my client. So my client is still paying the bill. And that is the exact opposite of the intention of the statute. So for these reasons, I'm respectfully requesting this committee to issue a favorable report for House Bill 153. Thank you, Madam Chair.
My pleasure, and thank you for the work you do. Who's next,
Thank you.
please?
Stephanie Means?
Good afternoon.
Good afternoon.
My name is Stephanie Means. I suffer from a lot of health disabilities such as seizures, syncope. I have rheumatoid arthritis in my knee, and I have laryngitis. But I myself applied for disability and was denied. Found out I was denied because I didn't produce the right medical records. I didn't know what medical records to ask for. So I, in turn, got a hold of Scott London and his team, and they worked due diligently on my case, getting the correct records so that we could go before a judge. I'm asking that you guys sit in favor of this bill.
Thank you for your time today. Really appreciate you. It's good when we hear from people that have been affected. So it made it easier when you had them to seek it for you, right?
Yes.
Okay. Next we have Riley.
Good afternoon, members of the chair. I'm sorry,
It's
members
okay.
of the committee, Madam Chair. I am a hearing manager at London Disability. I'm responsible for requesting medical records on behalf of our client. And it is one of the most complex process I have seen. For a client to request their medical records when they aren't sure what to request is kind of complicated. When I go and review a case for a client and I go through all their medical records to know what to request, it can list up to at least 20 sources sometimes, and we may get a bill for all 20 sources. Some of those invoices range from $80, which should be the max, and some of them I've seen go up to $800. And when a client wins a case and we in turn send them that bill to reimburse us, they can't afford it because they're already behind on certain type of bills waiting for their Social Security to kick in. So I do think it's important that attorneys should be added to the list of people who can get a copy of clients' medical records for free, because we do help the clients get a Social Security benefit and they're coming to us because they can't afford to get records. They can't afford to do a lot of things. So these records do help our clients get Social Security benefits, and some of them don't know the process of getting records. It is very complicated. We have about 10 different types of third-party requester websites that we use, and a client would not be able to go in and create a login for all of those and know what to do, how to pay the invoice, and what records are necessary and what aren't. So I do urge a favorable report on this bill. Thank you.
Thank you so much for being with
No
us and for providing your testimony.
Thank you.
Who will be next, please?
Presume that would be me, Madam Chair. Thank you.
So,
Good afternoon, members of the committee. My name is Andrew Sindler. I am a solo practitioner, and like my colleague, Mr. London, who I've known him and his staff for many, many years, I also dedicated my entire career to representing disabled and disadvantaged individuals throughout the state and now even different parts of the country. In an effort not to duplicate much of what has been spoken here today, because A, I've provided written testimony to that effect, and B, I don't want to duplicate. I would actually like to offer a couple of additional scenarios that I would like to bring to light that are going to basically demonstrate how rampantly and, dare I say, deplorably, medical providers and the third-party companies they use to provide medical records are going out of their way to use essentially what I refer to as a loophole in this law as it's currently written, to go against the original intention of the law. The scenario basically goes like this. I have a potential client that comes to me looking for representation, and as part of my due diligence, I request that they provide me a representative sampling of their own medical records before I agree to take the case on. So I'm certainly not authorized to request those records myself. So they, as the patient, go to their providers and say, I need certain of my medical records, and I'd like you to send them to this attorney directly to save the middle step. Very reasonable. Nothing in the current iteration of the statute says they can't do that. Well, they're being met with one of two different scenarios that's happening all over the place. Number one, these providers are getting slick to what they're doing and actually sending invoices directly to me, even though it's not my actual client and I didn't initiate the request. I just dealt with one today that I've now been sent 2 times by the same provider, third-party records facility. Or even more egregiously, I have had potential clients come to me and tell me that their providers are telling them point blank, you are not authorized to request your records. The request must come from your attorney. And I don't think there's a single person in this room that couldn't be further from accurate as current law here and anywhere in the country stands. So for those reasons, as well as every other reason that has already been explained, I would request the committee to issue a favorable report for this bill. Thank you.
thank you very much. Mr. Jarashaw, will you please come up?
Yes.
Oh, sorry.
Thank you.
Myself a seat here.
Good.
My name is Ronald Jarashow. I'm testifying on behalf of the Maryland Association for Justice in favor of this bill. As I mentioned before, I'm a former judge on the Circuit Court for Anne Arundel County. I went back into law practice. Under current law, a patient can request their records at a nominal cost, as we talked about earlier, under both the HITECH Act and Maryland statute. But that law does not provide for an attorney to get those records. There's a SIOX case in the position paper I submitted in support of this bill. I cite that case, and that case said that although the patient's entitled to get their records at a nominal cost, if they ask for the records to be sent to a lawyer or the lawyer's requesting the records, the healthcare provider can charge anything they want. And when we talk about Social Security disability, as mentioned before, you're talking about somebody who's disabled, not working. And in order to prevail, the standard for Social Security is that they must show they're unable to provide, to engage in any gainful employment. So I guess give examples to clients, such as if you can sit behind a gas station window and take money, you may not qualify for Social Security because you can do some work. So you've got to get, either you have one severe medical condition and you need to get your long history because generally it's severe because you've got a long history, or you've got a combination of medical conditions and you need to get all those records. So when you are asking for those, if the lawyer is asking for them, they can be billed hundreds of dollars. As you heard before, that ultimately comes out of the patient, the client's money, because either they have to pay up front or it comes out of the money that they're otherwise awarded. So we are supporting this bill and asking for a favorable report on the bill.
Thank you. And I have one last witness, Ms. Wanda Clark is also favorable.
She's not going, she could not make
Okay.
it today.
All right, so I will open it out for questions from the committee. Delegate Johnson?
Madam Chair, and for Mr. Jarshaw.
Yes.
If the attorneys are added to the list, how will they identify that it's for a Social Security case? And is there any room for those privileges to be abused?
Well, first of all, they would have to identify themselves under the statute. Generally, the letters, there's something called a high-tech letter I give clients. When I get clients to have that need their medical records, I give them the sample letter for them to go to the healthcare provider with their name so they can get generally the electronic medical record. But if, as many clients don't have that ability, they're saying, send it to my lawyer or whatever, the fee can be unlimited. Now, you're asking about abuse. Well, sure. A lawyer could conceivably falsify the statement to say, I'm getting this for a Social Security case. Maybe, and this may or may not be a falsification, they may have a combination. They may be pursuing and investigating both a personal injury and a Social Security. For example, I had a client who was burned over 80% of his body in a motorcycle crash, and we did a third-party case, and we did a case against the manufacturer, but we also got him Social Security. It's one of the cases I handled. So yes, theoretically, you're right, but a lawyer falsifying, as we now know from the recent news, a lawyer who's lying suffers a potential penalty.
And if I actually may just quickly add on to that.
We only allow one person.
Oh, I'm sorry. I
Yeah, it's all
apologize.
right. He can have a follow-up, but.
Yes,
it's
because
up
I
to
can
him.
address that. Thank you. What was the clue? Okay. Thank you very much. And I apologize for speaking out of turn,
okay.
but I thought this was actually important to address because this does come up in our practice regularly. And I know Mr. London can probably speak to this as well as his staff. So there are providers who are familiar with the current iteration of the law and are rightfully choosing not to read into it that attorneys don't come under the umbrella the way it's currently written as personal representatives of the patient. But what many providers are asking for as a prerequisite before releasing the records for free to the attorney is to provide documentation proving that it's not only for a Social Security matter, but that the attorney is representing them for the same. So what we are routinely doing when we send these requests out is we are sending, at least for our existing clients, a copy of the signed 1696 appointment of representative form. That's the Social Security prescribed form that must be included as part of our representation. So it's signed by the patient / client, it's signed by us as the attorney. And that's how I don't want to say for certain that part of the process couldn't potentially be falsified, but I don't think it's likely to happen, at least not for a member in good standing of the bar wanting to bring hot water onto themselves. So I think that's the way around that essentially. Sure.
My pleasure. Thank you. I like that. You follow right along with a follow-up. Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Rosenberg, for bringing this bill. It's very interesting. I happen to be a physician's daughter, and so I was bred to look suspiciously on attorneys. But you guys make a a persuasive case. I was trying to open my chart, and the reason why is because but I couldn't get it open quickly enough. As I recall, when a person goes to the doctor, there's usually, like, say you go for your regular appointment, you fill out a sort of check-in form. You let them know, you have any new conditions? What's the reason for your visit? And if I'm not mistaken, there's a place on these forms that says, do you authorize anyone else to view your medical records? Is there any authorized person?
Mhm.
And at that point, you can indicate my mom, or seems to me, my attorney.
Mhm.
So if that's the case, if there's an option that already exists in our medical record intake system to designate another person, for example, an attorney, to have access to your records, is this bill even necessary? And if so, why?
Okay, yeah, I guess I became the designated spokesperson. Thank you, Delegate. So I think there's a twofold issue with that. The first one would probably primarily be the fact that when a patient establishes care with a provider, regardless of whether it's some new condition, some existing condition, maybe they're switching providers, they may not know at that moment that this is eventually going to develop into what will become a Social Security disability claim. A lot of people develop conditions that aren't necessarily disabling by their nature, so they're not thinking at that moment, well, I better give my attorney or an attorney, if they don't even have one at that time, access to it. Now, theoretically, maybe they could go back and supplement that form. Maybe they could revise that form to add the attorney in, which is something I think they can typically do anyway. I think that's all part of the normal HIPAA and high-tech process as far as authorizing individuals to request and receive records on behalf of a patient. But I think it still doesn't get to the root of the problem, which is that if the attorney is the one initiating the request under the current iteration of the law, it's still allowing the providers technically to charge the fees that they're going to charge, which, and this hasn't been directly stated, I don't believe, but just so the entire committee is aware, and this has been addressed also before the Senate Finance Committee, is that these costs really add up on these cases because our average client sees probably at least 4 to 5, maybe more providers at a time, not to mention hospital visits and how hospital records can be just astronomically off the chart. Even when we're requesting them electronically, I mean, the fees really do add up. And oftentimes we have to initiate these requests multiple times throughout the course of a representation at the different levels of a claim, the initial level, the reconsideration, the ALJ hearing levels. And we're not requesting duplicate records, we're requesting updates, but each time those costs can really, really get significant. And I'll speak personally just for myself. I'm a one-person solo practice. I have to watch my bottom line. So I can say to my clients, I'll advance these costs for you, but I do have to pass them along to you if the providers won't waive them away. So again, it comes back to what the root intention of this law was in the first place, which was not to have our clients bearing this burden when they've already got so much they're dealing with as it is. Yes.
Thank you. And thank you for the clarification. Delegate Bagnell.
Thank you, Madam Chair. And this is just a process question because we often hear about dates in this committee. We have the unwinding, we have the health benefit exchange. Just to confirm, because these are Social Security disability benefits cases, these are ongoing, correct? There's no like window of time when these cases are taking place. They're ongoing.
I guess as to your question, so these don't work like a typical lawsuit necessarily. We file them when we file them. There's no really concept of a statute of limitations. We have deadlines at each level of a claim of when we can appeal something when a denial or unfavorable decision is issued. Yes, the process of it can drag on literally for years at a time. We all have borne that burden of cases that have just stuck with us for seemingly a lifetime. I got a case that I've been working on since 2006, literally, that's still going on as we speak. So yes, it is something that in a theoretical sense, there could be no end date in sight as it's happening. And yeah, we have to keep bearing the burden of continually updating those medical records. That's an ongoing obligation that we have with Social Security. No problem.
That doesn't mean you're gonna get another one. Just kidding. Just kidding. Delegate Hill.
Thank you, Madam Chair, and thank you all for being here, Delegate Rosenberg, for the bill. So the question is, following up on Delegate Johnson's inquiry, would you be opposed, Delegate Rosenberg, to any kind of language that would say, you know, to the effect a lawyer who makes clear to the provider of whom the records are being requested that this is the purpose of those records, right? Because the provider's providing it and not getting compensated. The lawyers, we're trying to do that, but I think even though one of the witnesses says he provides a form, I don't think that's uniform. And I think for a practice to be told waive your fees, it ought to be clear to them that this is a Social Security case, as opposed to they can't tell what it's for because typically it just said we have permission from the patient to request the records. Please turn over the records.
So I think it's a similar question from earlier in that the statute itself says specifically at the bottom, only for the purpose of Social Security disability. And the form that the other attorneys were referring to is a standard form used by every Social Security lawyer. It must be used. There is no exceptions under the Social Security law, which would be submitted.
It's the form that Social Security requires. What this gentleman says is he also sends it to the provider. All attorneys don't do that. So since it's such an easy form, would it be a big deal to say in here that the attorney must, or provided the attorney notifies the provider however they want to with a separate letter by submitting that form that this is indeed what this is for.
If I may, it's just for clarification purposes, the current law, chapter 157 of 2021 prohibits a healthcare provider or a representative of the healthcare provider from charging a fee for providing copies of a medical record, one, requested by the patient's personal representative or an employee or other representative of a nonprofit legal service entity or other volunteer or nonprofit program. And two, they will be used to support a claim or appeal for Social Security disability income or Social Security benefits. And then if you look at the bill on page 2 and you look at line 11, current law says they will be used for the purpose of filing a claim regarding or appealing a denial of Social Security disability income or Social Security benefits under this title. It's already in the law.
Know about it. It says the provider can't charge for it, but there's no clarity that they know.
So what you're asking is that if we're gonna pass this bill, that there's a requirement that the lawyer must tell the provider that it is going to be used for Social Security purposes.
Yes.
So what do you think about that?
Agree.
Yeah.
All right.
Fully.
There you go. Sometimes we just need to work together and clarify it. Are there any other questions? Delegate Rosenberg, if you can request that amendment for the subcommittee, okay? Any other questions? Seeing none. Thank you so much for your testimony today. We really appreciate it. I actually believe that there are no other witnesses, so this actually ends the House Bill, the hearing on House Bill 153. Delegate Hill, before we go on to the next bill, did you solve that other bill? Okay, great. You can let the subcommittee know. Thank you. I knew you could do it. All right. So we have next, House Bill 461, Delegate Martinez, Health State Advisory Council on Quality Care at the End of Life renaming. Can you be so kind and bring your panel, please? Thank you. And I believe you have Gail Manzel, and I hope I pronounced the name correctly. Okay. Sometimes my Spanish kills it. Go ahead.
Well, thank you so much, Madam Chair and colleagues. For the record, I'm Delegate Ashanti Martinez, here to present House Bill 461, the Health State Advisory Council on Quality Care at the End of Life renaming. This bill intends to replace the original name of the State Advisory Council on Quality Care at the End of Life to the State Advisory Council on Serious Illness Care. This advisory council plays a critical role in overseeing and analyzing the various different approaches to care that are given to patients with life-limiting illness here in Maryland. They're responsible for monitoring the state's laws, policies, and regulations that affect the end-of-life care plan, and if they're found impractical, they provide recommendations and improvements and revisions to the responsible state agencies. They also work closely with the governor and the General Assembly to follow through with assigned duties and work together to improve the quality care of end of life. And the name change is to better reflect the critical role that they not only play in advising the provisions of end of life care, but also give more prominence to the council when they give advice on legislation that affects patients who suffer from long-lasting critical illness. This summer, the speaker appointed me to this State Advisory Council. In the first meeting, I was tasked with getting this name change. So I want to be a good committee member and ask for a favorable report. Thank you.
Thank you. Thank you for your testimony. Hi. Good
Hello,
afternoon.
thank you. My name is Gail Mansell. I'm the Director of Supportive Care and Pastoral Care Services at Atlantic General Hospital, which is in Berlin, Maryland, about 7 miles from Ocean City. So come to the beach. I've been a member of the State Advisory Council at End of Life Care for more than 16 years. The State Advisory Council for End of Life Care unanimously supports Bill 461 to change our name to the State Advisory Council on Serious Illness Care. For over 20 years, the council has played a vital role in advising the legislature and state agencies on issues regarding serious illness. It has been the instrumental company and council in developing tools for chronically ill individuals to make choices about their health care, such as advanced directives and the MOLST form. The council has had a special focus on end-of-life care, and while we will absolutely continue to advocate for those issues, we believe it is also important to highlight our role in improving care for all Marylanders living with the burden of serious chronic illness. The need for an updated name change is shown by the council's recent collaboration with palliative care workshop work group sessions, which were convened by the Maryland Healthcare Commission as directed by the General Assembly. Their report adopted a definition of palliative care from the National Center to Advance Palliative Care, which says that it is appropriate at any age and any stage of serious illness, with or without curative treatments. The name State Advisory Council on Serious Illness Care will better reflect our role in advising policymakers on the care of all Marylanders impacted by chronic illness, including those nearing the end of their life. Thank you.
And thank you for your service to the state of Maryland. We're really grateful. I'm going to open it up for questions now from the committee. Are there any questions? You did an excellent job. There are none. Thank you very much. And actually, this concludes the bill hearing on House Bill 461. We're now going to go to House Bill 353, Delegate Collison, Maryland Department of Health 211, Maryland Oversight. And if you can come with your panel, and if I may call the following people, Quentin Askew and Felicia Porter, will you be so kind and come up, please? Hi, good afternoon.
Good afternoon, Madam Chair, and honorable friends of HGO. I don't believe Ms. Porter is here. So we'll proceed without her, but thank you so much for giving me the opportunity to speak to you today about HB 353, which is Maryland 211 oversight. And this morning we listened to the governor, I guess it was the afternoon, we listened to the governor, and he repeatedly said the word partnership and partner, and he spoke eloquently, as he is wont to do, about the benefits of us working together as legislators, as government and business, as government and nonprofits. And I've been involved in 211 Maryland for about 12 years now, in some capacity or other. I've never been a call center operator, but I've been supportive of the program, and I was on the original oversight committee for the program for 7 years. So, and over those 12 years, I have seen the capacity and the services and unfortunately the need for services of 211 grow. 2 years ago, this body saw fit to pass a bill that would eliminate the oversight committee because it really had no authority. And a lot of us were spending a lot of time wondering and wishing we could do things that we couldn't do. So we abandoned the oversight committee and said that MDH, that the operation, the partnership would be with MDH. And last year, I came back to you with a bill saying, you know, the bill didn't intend for the original bill to eliminate the oversight committee, did not intend for MDH to become the complete oversight body for the 211 program. In fact, one of the rationales for taking the ineffective oversight committee away was the 211 board was actually extremely effective in growing the program and delivering the resources. So it was, we gave them more money. We gave 211 more money in order to meet its mission. And in doing so, we charged MDH with making sure that they were using that money responsibly. The previous administration took that role a little bit farther and became took on the role of being the complete oversight body for 211, which meant they were evaluating call centers and, in general, not being actively engaged, but rather simply being evaluative in the process. So last year I came back to you with a bill that said, let's alter the role of MDH in the 211 program and have it be evaluative of the financial aspects only. That bill last year passed this House 132-0. I'm back again this year because it did not get a vote in the Senate. And I am hoping that you will see the value in continuing to allow 211 to run its program with the fiscal oversight from MDH. There is a letter from MDH in your system, and they've spoken to me about their concerns, which are to clarify 211's role with respect to behavioral health coordination. Apparently, that is a very specific set of words that has a very specific set of meaning and very specific meaning that is not appropriate in the context that it's stated in the bill as we've written. So they do tell us where to put that information in order to make it correct. The other small change in this bill is we went from phone to, I think it's telephonic now. So to allow us to use all different kinds of telephonic devices in communication with 211. 211 over the last few years, especially through COVID, has been a lifesaver for many, many Marylanders. And I know that it is a greatly appreciated service, and I hope that you will consider this bill and pass it favorably. And I'm going to turn it over to Mr. Askew, who will explain a little bit more about what 211 does and the benefits it serves.
Good afternoon, Mr. Askew.
Good afternoon, and thank you, Madam Chair, members of this committee. My name is Quentin Askew, and I serve as the President CEO of Maryland Information Network. I want to first thank Delegate Kellison for her unwavering support and her commitment to our citizens. So Maryland Information Network 211 Maryland is the state's health and human service referral line. So we're available 24/7, 365, providing support to any Marylander who needs it. This bill, I ask for your support in House Bill 353, really helps us to clarify the language and relationship with the Maryland Department of Health. Over the past year, the organization has grown. The organization has evolved with our board. We're no longer this reactive service, but a proactive service and partner with our state entities. We provide texting services with our Maryland Department of Emergency Management. We provide behavioral health support for our behavioral health administration, as well as providing care coordination services for our emergency room departments. We have evolved our services. We utilize our technology to support connections for those that are in need. We ask for your field support with this bill because it allows us to speak to the evolution of our organization, the evolution of our board, and to provide us support and connections to continue to serve those who are in need. Over this past year, there's been over 1 million individuals who have connected with us, whether it's by phone, text, chat, or website support. We continue to evolve our services. We continue to seek partnerships with our state partners, our community partners, our call center network that has provided an enormous amount of services for us to work with. So again, we ask for a favorable report for House Bill 353. And again, we appreciate you listening to our bill.
Thank you for your service to the state of Maryland. Is Ms. Felicia Porter here? She's a city council in Baltimore City. I do not see her. All right, so we're going to open it up for questions. Are there any questions for this panel? I first see Delegate Johnson.
Thank you for the bill. This is just a point of clarity. So is the concern from the Maryland Department of Health incorporated in the bill, or is that an amendment you would be open to in subcommittee?
It's an amendment that I'll do in subcommittee. They just told me about it yesterday.
My pleasure. Anyone else for this panel? Seeing none. Thank you very much for your testimony today. We really appreciate it. And this actually, we have one more witness and that will conclude the hearing. Thank you.
Thank you, Madam Chair.
You're welcome. We have an unfavorable in-person oral statement from Mr. Franklin Baker, the United Way of Central Maryland. Good afternoon, sir. How are you?
Outstanding.
That's wonderful.
I have one of the most difficult jobs in the world, to be in an unprovable status against the beloved Cullison. So as you said, Madam Chair and Vice Chair, thank you so much, committee members, for allowing me to testify. Franklin Baker, President and CEO of United Way of Central Maryland. We are here to address our opposition to House Bill 353, 211 Maryland oversight. We have been running one of 211's call centers for over 3 decades. We are the owner of the 211 Maryland Resource Database. We are a big supporter in caps of the 211 system, but we're very troubled by the proposed legislation and what it would mean for the future of the 211 system in Maryland. As one of the 4 founding members of Maryland's 211 system, we want to do what's best for the people we serve every single day. Annually, nearly 600,000 people connect to 211 Maryland by phone, website, text, or chat, often with complex health and human service issues and needs. So continuing to have a high-quality 211 system is vital to Maryland residents. Maryland Information Network, or MIN, also known as 211 Maryland, Inc., is a small nonprofit that the 4 founding 211 Maryland organizations, Community Crisis, Inc. of Hyattsville, Life Crisis Center of Salisbury, the Mental Health Association of Frederick County, and United Way of Central Maryland, created to be a coordinating body for the 211 Maryland system. MIN is not a state agency, but with this legislation, it would become much more than a coordinating body. The legislation would place the 211 system in the hands of this small nonprofit that would not have the needed supervision, oversight, and transparency. We are deeply concerned, and all 4 founding organizations oppose this legislation. Men should not be given additional power over the system, particularly when its vision to adversely impact the system's effectiveness and our service to the people of Maryland. And I'll fast forward for my remaining comments, Madam Chair. Our collective 211 leadership far exceeds that of men, and we are committed to transparency. Our involvement, control, and impact on the 211 Maryland system are critical. And so it is in the best interest of all Marylanders, especially those facing complex health and human service issues, to have an effective 211 system. So we stand ready to work together to help make this system better, as the governor says, so that no one is left behind. But in our view, this legislation makes the system worse, not better. So for these reasons and more, we are saying, please vote no against HB 353. Thank you.
Thank you for your testimony. And I usually, my members go first because I like to wait. A lot of times the questions that are in my mind are answered, but I do have a question for you. I know that last year this bill passed unanimous, and I don't recall for the life of me you testifying. Am I wrong?
We missed the deadline, I believe, but we did talk to the various sponsors offline.
Yeah, because I know we didn't hear from you. The committee didn't, and we're pretty open, like things go to subcommittee, we welcome everyone. So that's why I'm a little bit surprised. So good, because I was thinking, wow, I don't remember. Am I missing something? The other question I have is, so tell me what is going on that you're sort of at odds? What is it that we're trying to do here and fix? Where do you think there's a disconnect?
Well, as you heard from my colleague, Quentin Askew, the president and CEO of MEN, who works very closely with myself, my team, and the 3 other founding call centers throughout the state. We have a partnership, we work together, but there are just still ongoing concerns. And the idea of having them to have more autonomy over this really, really more complex and important system for the citizens of Maryland without oversight from a body like the Maryland Department of Health or some other pathway that ensures there's accountability, not only for service, for payment, for connection, for communication, for knowledge, all those things that we have deep expertise, having done this for 3 decades as 4 founding call centers. Use of the expertise of each of the existing 4 call centers is extremely important. We don't see that consistently happening. There's things happening that would never really come to the body here assembled today, but we just want to make sure that we work together as an actual committee and other key stakeholders to find an appropriate pathway so that the 211 system that many of us beloved, many of us really care deeply about is working effectively, is in fact the pathway forward.
So could you, because as I sit here, I'm thinking this is like a company and there's a fallout and, we're coming in to try to fix it, which is not always the best solution, right? Have you sat down to see if you can come and to some acceptable term or body that you feel comfortable?
Well, I'm hoping that this body would either have subcommittee discussion or committed to study over the next few months with the appropriate stakeholders to figure out, co-create a pathway forward. This is too important of an item for us to allow MEN to totally have or mostly have autonomous control over how everything happens within the 211 Maryland system. That is the concern. And that's the honest truth from our standpoint. It is not that we're against this notion of moving forward with continuing to pursue technology and all aspects of how do we make more effective connections with our Marylanders. It's the notion of having this MEN, a nonprofit in the community that doesn't have, in our view, expertise, the deep knowledge, the expertise that's really so important to advance the 211 system in Maryland, to make sure we have some way where we feel comfortable and our citizens in Maryland feel comfortable that we have the most effective resource database and that all the information that's being communicated is reliable and trustworthy, as has been for 3 decades under the leadership and management on the day-to-day basis in the trenches throughout the state through these 4 founding call centers. So if there's a pathway to give us that assurance, we'd be all over that.
Okay. Delegate Shalega, thank you.
Thank you, Madam Chair. Thank you for being here. Just by the way, you keep saying men and I keep hearing men.
Oh.
Like men, what? Sorry, but
and Delegate Shalega is saying, no, not to a man, give it to a woman.
I know, I'm like, men shouldn't do this. I'm like, what?
No offense.
Just solve the problem. You just solved the problem, Chair.
But with all seriousness, so I'm reading the fiscal note. 211 Maryland is a private nonprofit organization. What is the fee structure? How are you funded?
So they fund our four call centers through funds that was just spoken about by Vice Chair. So we get funding from that source, and it's less an issue of funding, but in some ways it still is, and I'm sure Quentin would agree with me. There would be even greater success if there was more funding, coming from the state to be able to do some of the additional work that's desired. But it is funding from the MEN organization, Maryland Information Network, and it goes to each of the call centers.
So how are you different than 988?
And what respect?
Isn't that the number?
Mental health. Yeah.
Yes.
Yeah.
Are you do you cooperate with them? Are you?
So 3 of the 4 call centers participate in that program. That's a separate, revenue source, separate operation, but it's under the information referral service umbrella that MEN organizes for the state.
Confusing to people to know, do I call 211? Do I call?
My personal
988?
view is, even though I'm outnumbered by so many people across the country, is it should just be one number that they patch into 211 in my view, but there are others that say the 998 is a better vehicle for that specific service. For purposes of the number itself, is more, it actually is an advantage on how the queue system works for when you call the numbers. So there are some advantages to 988, but in my view, it should be 211, and then you patch in the behavioral health individual that needs that service. But the actual process is long down the track, right? There's long down the track of people in favor of having that 988 number and advancing it nationwide. So there's like a parallel 211 and 988. Yeah.
And for clarification on 988, came from the federal government to make
Correct.
sure that
That's
all the
correct.
states have the same number for people that are having severe, mental health crisis. And 211 is for everything, right? You can call for you're losing your home, you need a place to find food. I mean, that kind of stuff, right?
So, Madam Chair, we have a slogan. This will be easy for all of your committee members to remember. It says there are more than 211 reasons why one should call 211.
Mhm. That's really, really good.
Yeah.
Yeah, it's really good. All right, so I had Vice Chair Collison and then Delegate Hill, then Delegate Johnson.
Yeah. Thank you, Madam Chair. Mr. Baker, if I was rushing earlier when I saw you in the hall, I apologize. I was
No worries.
dealing with a little bit of an
No
emergency. But thank you for coming today. And do you have the opportunity to meet with Quentin and the 211 board and participate in, the evolution of the programs, give feedback,
We do.
support them? So
Yeah, we do.
is that kind of a regular ongoing thing?
Very much so. There's operational meetings with some of my team members and team members on Quentin's team, as well as the other call centers in the state to talk about operations, things like that. Then there's the occasional opportunity to speak with the board, concerns or possible collaborations, et cetera. So yes, that is happening.
Delegate Hill, followed by Delegate Johnson.
Thank you. And thank you for your testimony. I was, a colleague who was pulling up your letter from a year ago. I guess I'm a little confused because the bill sponsor, Vice Chair Collison, talked about how the current board doesn't really do oversight. They don't have the authority to do what they're doing, so they're trying to put it back. And you're saying that I'm not clear, is there oversight now? Or is it non-functional oversight? And I'm not clear who you think the oversight should be under.
Well, I'd rather not get into that piece because I understand the play of MDH and HHS and some others that might be likely suitors for oversight. But I would just say whatever that particular oversight body is, it should be someone who's connected to the governor's office in some way. In the event that there are concerns with quality of oversight of this particular organization, MEN, and the work they're doing in partnership with the 4 founding call centers and the quality of the services that are rendered through the 211 service throughout the state. So if in fact there's calls in to 211 Maryland Inc. or MEN, and there's no oversight body at the state level, it can cause some critical concerns that bubble up to the governor without having a body that's ultimately holding the MEN as well as the 4 operating call centers accountable to quality services to these 600,000 callers every year. That's really the main issue, is just making sure we don't have men with a little bit more authority than we deem necessary from the standpoint of not having enough oversight at the state level that will ensure that if there are issues or concerns, if quality slips, there is an accountable body that men has to report to, right? That's really the main issue, Madam Chair and Delegate Terry Hill.
Delegate Johnson.
Thank you, Madam Chair, and thank you for coming today. You know, it's not often we get folks that come and testify that says we need oversight and accountability. So it's pretty refreshing. So my question is, you obviously have some concerns. So are your concerns mainly focused in the financial end, the service provided end, the record keeping end, or is it all of that?
It's all of it. And it is, as I stated in my remarks, it is also, we believe that 4 founding call centers working in partnership should be a part of actually helping 211 as a system to move forward in the future. And we just are not 100% sure that the sitting entity should be in the sole seat. It could be some sort of combination, some work that we do. We need a pathway to make sure that the future is secure for 211. I'm not necessarily even referring to some of the other pieces right now, like 988 and other services that are under men's umbrella now. But I'm just specifically talking about 211 as a system. There's got to be a viable pathway where we feel 100% confident that the people we're serving every single year are getting optimum quality and care, and the operational components are effective. They're merely making a difference, right, in terms of how the recipients of the services feel the services, have levels of quality that are very, very high. And we're just concerned that our expertise and the current construct is not optimally leveraged. We feel like there's much more that could be added to the mix to make this a more improved system, and it's just not leveraged in the way that we believe. Now, Quentin might disagree. He's my friend. He might disagree with that, right? But that's just my perspective and our perspective.
You're welcome. I don't see any other questions from the committee, but I do have a request of you.
Yes.
And I would like, before you leave today, if you could stop by, and I haven't asked her, but about a time, but I know her and she is more than willing. She said she's willing to meet. If you could stop by the vice chair office and request a meeting with her, please.
Absolutely.
Either a meeting by phone or it could be virtual as well. So that you can talk about what is a solution that you can all live with. Okay?
Sounds good.
Thank you. And this actually concludes the bill hearing on House Bill 353. And you know where our offices are?
Yes.
Right next door?
Mhm.
Thank you. And let them know that we okay. Thank you so much.
Thank you.
And thank you for the work you do for Maryland. We really appreciate it.
Thank you.
Next, we have House Bill 51, Delegate Rosenberg. And it's actually Maryland Pediatric Cancer Fund modifications. And Delegate Rosenberg, you have Ruth Huffman. If Ms. Huffman, will you be so kind and come up? And as soon as you sit, you can get started. Thank you very much. And for those of you that are waiting for your bill, be patient. We're moving right along. I think we're making great timing. Go ahead. Now I jinx myself probably, but go ahead.
I'll do my part.
Okay.
Thank you, Madam Chair. House Bill 551 would amend in light of the practice and experiences of the last 2 years since the Pediatric Cancer Fund was created by action of this legislature to make certain revisions, modernizations, if you will, of the existing fund. First, the current law allows that the money in the fund be used for research, prevention, and treatment. As Dr. Sivan, who will be testifying virtually, has said to me, the treatment money that's allocated, or the money that's budgeted for the fund in one fiscal year could be consumed by one treatment. It can be that expensive, one child, one patient. So the long-term benefit is far greater if this money goes to research And that would be of, in the long term, more benefit to more children. Secondly, the original law provides that the Secretary of Health may distribute money from the appropriation to a promotional account to encourage donations. And it's the view of the department, it's my understanding, the view of the department, that they don't feel capable of, they need some guidance from us on how best to do that. And the language here would provide that that money go to a state-based child cancer organization. Full disclosure, that could very well be the organization that Ms. Huffman is the director of, the principal of. Finally, the bill creates a commission to oversee the award of the competitive grants under this program. And that would range from developing the enumerated use or authority of the commission would range from developing the criteria for applications for grants and to conducting progress reviews of grant recipients. Very scientifically or medically oriented is the membership, the proposed membership of the proposed commission. So this committee recognized, in summary, this committee recognized 2 years ago the need to create this fund, and experience over the last 2 years brings us here with the bill as we propose the amendments to update and upgrade the commission so that it can best serve our children who have pediatric cancer, so that, like your daughter or son?
Daughter.
Like Ms. Huffman's daughter, who is now an adult. Thank you very much.
Good afternoon. How are you?
Good. Thank you for the opportunity to testify. So my name is Ruth Hoffman. I am a proud Marylander and the CEO of the American Childhood Cancer Organization, or ACCO. ACCO, which is located in Maryland, has actually been the leader in establishing federal funding for childhood cancer research since 1970, funding which sadly has failed to meet the research needs of this vulnerable patient population. In 2018, ACCO identified only 11 states that included childhood cancer objectives in their state cancer plans. This was largely based on cancer screening and prevention strategies to decrease adult cancer deaths. Children did not smoke to cause their cancer, so prevention strategies will not prevent it. Additionally, only 2 states provided funding for childhood cancer research, yet almost all states appropriated significant funds for adult cancer research. To address this research disparity, ACCO has successfully secured $98.8 million in appropriations in 7 states, including Maryland, with 5 more states in various stages of passing legislation. But I'm also here as the mother of a daughter who in 1987, at the age of 7, was diagnosed with acute myelogenous leukemia. My daughter was given a 5% probability of surviving and reaching her 8th birthday. Fortunately, she became one of the first children to survive a bone marrow transplant. She was treated with toxic chemotherapy and total body radiation. But her survival came with a cost. She's endured a secondary cancer, has endocrine dysfunction, lymphedema, and she recently learned about 2 weeks ago that she's officially in heart failure. Just 6 new drugs have been approved by the FDA to treat childhood cancer in the last 30 years, compared to more than 220 new drugs for adult cancers. It's been 37 years since my daughter's transplant, and sadly, treatment for childhood AML and most childhood cancers have not changed. Cancer remains the #1 disease cause of death of Maryland's children. Your support of the amendments of Maryland's Pediatric Cancer Fund Act will clarify and operationalize the distribution of the appropriations to address the unique needs and the unique research needs of our state's littlest cancer patients.
And thank you for being with us. And I'm really sorry about your daughter's diagnosis. I hope she recovers. And
thank you.
Thank you for being here. It matters. I'm going to open it up for questions now. And
Madam Chair, could I ask if you take the virtual testimony, or if that gets?
Sure, if you'd like me to do that.
Dr. Sivan.
He testified favorable with amendment, which is why I'm doing the favorable first. But if you like, I'll do it.
If you could, please.
Absolutely. One
Thank
minute.
you very
Delegate
much.
Shalega, 1 second. Thank you.
Yeah.
Will you please bring him on? Thank you.
Dr. Sivan and I were contemporaries at Amherst, but and both majored in the sciences. But I majored in political science. He majored in the medical sciences.
Medical science.
There we go.
Good afternoon, sir. How are you?
Good afternoon. I'm honored to testify today, and I'm a little under the weather today with an upper respiratory infection, which I don't want to spread to you. So thank you
Well,
for
we
giving
appreciate that.
me the opportunity to testify from my basement here. So my name is Kurt Sivan. I'm a professor at the University of Maryland. As a pediatric oncologist, I've been privileged to make breakthrough research discoveries that cured my patients. I want to do this again and again and again. I'm here today to ask you to support the proposed amendment to HB 51, Maryland's Pediatric Cancer Fund Act. This does two things, this amendment. First, it clarifies wording to restore the original intent to provide new support exclusively for pediatric cancer research. Research on childhood cancers is woefully underfunded, and there are other mechanisms that address the much larger costs for pediatric cancer treatment and prevention. Second, this amendment proposes a description of the structure and operations of a commission of pediatric cancer experts who would work with the Department of Health to review research grant applications and choose the best for funding. As an example of research that might be funded by this work is work that my own lab does on molecules that drive acute myeloid leukemias, which you'll hear more about from Ms. Hoffman. Treatment for children with AML, as you'll hear, has barely changed over the 45 years that I've been a pediatric oncologist. My lab is now working to discover new molecules that propel these AMLs, and we can attack these new AML target molecules with novel compounds which will become better and less toxic leukemia drugs. So I also ask that as members support reinstatement of the critical funding which was eliminated from the upcoming budget for HB 51. Annual state funding for childhood cancer research will discover life-saving treatments for children battling cancer. Thank you very much.
Thank you very much for your testimony, and I hope you feel better. And thank you for not getting us sick. We're so grateful. We're going to open it up now to Delegate Shalega.
Thank you, Madam Chair.
You're
Thank you. I'm
welcome.
so sorry to hear about your daughter. And
Thank you.
certainly we all hope or pray that she recovers and has a long life. So I have a couple two-part questions. So the first one's probably for Delegate Rosenberg. So in reading the fiscal note, it looks like this fund was defunded last year and again this year. Is that right?
Well, the governor has proposed not funding it, and there's language in the BRFA, the Budget Reconciliation and Financing Act, that's needed to carry that out. I would hope that this committee would, I'm sure we will have a representative at the hearing, so on the BRFA later this session, so that both Dr. Sivan and Ms. Hoffman can make the case there for keeping the money or for not making that change, for restoring the money.
Was this fund also to contain federal money, right? We didn't just, it's only strictly for Maryland funding. So I guess I'm a little bit torn. You want to take treatment of kids with cancer out of it.
So the original intent of the bill was it actually, it was almost like a typo. And because we're doing this across the country, so the focus really is on research to enhance treatment, research to improve treatment. So again, as I mentioned about drug development, we just haven't made the progress that adult cancers have made. And so funding an individual child's treatment, there's other mechanisms. We have Medicaid, we have, individual health insurance, we have other systems that will handle and take care of that. So what we don't want is, the funds to be spent on one child's bone marrow transplant, for example, and then not have the research progress, happening in, drug development and, treatment for all children with cancer. So that's the purpose. And
clearly we need more research, obviously, from your
Right.
testimony, but so can you assure us that a child would not get treatment? That's what I would be concerned about, taking that language out. If the choice that I'm assuming a board would make, if the choice was, we have a child that's, fallen in the donut hole for help, so they don't qualify for Medicare. I mean, Medicaid, they're young. They don't qualify for Medicaid. Their folks have insurance, but with a high deductible. And, so we're, I'd hate to cut out a kid from getting treatment to fund research instead. So assure us that's not going to happen.
No.
Dr.
So-
Steven, could you answer that? Because only one of us can answer.
Yes, I'll try. Obviously, I'm a pediatric oncologist, so diagnosis, treatment, and also prevention are certainly concerns of mine. The cost of those is immense, and that's borne by our medical assistance program and insurance, as Ruth said. And if somebody falls in the donut hole, it's the job of the pediatric oncologist, the social workers, the teams. And we do a really good job of getting care for those patients in Maryland. If we were to make it easier if that's my right hand, with these monies, we would only make it $5 million easier. The problem is much, much bigger than that. Supporting research is a different endeavor. That was the purpose of the bill, to make it unnecessary to give the toxic and horribly expensive treatment that we're giving now. But that is a someday thing.
Okay. Any other questions or concerns? Seeing none, thank you very much for your testimony today, all of you, and I hope you have a blessed evening.
Thank you.
Okay.
Thank you.
Thank you.
This actually concludes the bill hearing on House Bill 51. Next, we have House Bill 177, which is Delegate, actually, Delegate Lewis, do you mind if I call the next one first? Because you're here and they have a child. Is that okay? Delegate T. Morgan, House Bill 96, is he here? I'm going to call you next, okay? All right. And that's Health Newborn Screening Program. You want to come? Yeah, they're coming. And thank you for being flexible because they've been waiting. Okay, thank you. Yeah, I just wanted to be, thank you so much. Okay. Good afternoon. How are you? And thank you for waiting. Good afternoon, sir.
Thank you,
How are
Madam
you?
Chair. Thank you, Madam Vice Chair and members of the HGO Committee. I am, for the record, Delegate Todd B. Morgan, not to be confused with the illustrious Matt Morgan, who sits in this committee. Ladies and gentlemen, today I'm here to, for the purpose of introducing House Bill 96, Newborn Screening Program, Krabbe-Gupta Dystrophy, is to add this order to the list of diseases screened by the Newborn Screening Program. Please bear in mind, I'm a defense contractor by trade, and my science skills probably in when I took chemistry and biology in high school, and I have my 50th high school reunion coming up this summer, so you can do the math. It had been my hope to have a doctor here today to be able to assist with my testimony. However, all the doctors in this specific field are attending the World Conference in San Diego, and it's probably raining there. We were able to get testimony from two nationally renowned specialists to provide written testimony, Dr. Michael Gabb and Dr. Joanne Kurtzenberg, and their testimony is in the file. since we've been here before, I know how often we enjoy reading the testimony that's been provided. But I think the stuff that they provide is very powerful, and I would encourage you to please take some time and read it if you don't mind. I began learning about this bill last summer and contacted HGO leadership for guidance, since there were no surprises in this bill, and I really didn't know where I was going as I went down the path. I met with the representatives of the Federal Advisory Committee on Heritable Diseases in Newborns and Children in November. I then met with the Maryland Department of Health and the Advisory Committee in December of 2023. The key to this bill's introduction was a successful recommendation by the Federal Advisory Committee on Heritable Disorders in Newborns and Children and Krabbe diseases and their recommendation to the RUSP. Had this not happened, I wouldn't be sitting here today and the bill would have been withdrawn. Krabbe disease is a neurological disease caused by the absence of an enzyme which leads to the loss of myelin, which causes the nerves in the brain to be unable to communicate. The symptoms begin mildly around 4 to 6 months of age, but they quickly progress to blindness, deafness, seizures, decreased mobility, and eventually death. If you look up Krabbe, you'll see that the life expectancy for these children doesn't look very good. Early detection of infantile Krabbe disease allows for a transplant, which can dramatically improve the quality and longevity of a child's life. However, this operation is usually done before the child reaches 6 months of age. Most often, by the time the child is diagnosed, it's too late for the transplant. Sadly for the child, the disease attacks the nervous system, causing muscle weakness, pain, numbing, redness, burning, tingling sensations, especially in the arms and the legs. The bottom line, it's a very, very painful disease. And how do you explain this to a 1-year-old who's suffering? And in particular, how do you deal with this as a parent? On January 30th, 2024, so we're within about 10 days, folks, the Advisory Committee on Heritable Disorders in Newborns and Children recommended to the United States Secretary of Health that infantile Krabbe disease, IKD, be added to the recommended uniform screening panel called RUSP. In keeping with the federal recommendation, I have drafted an amendment, which you have, to this bill, which would limit the testing only to the infantile Krabbe disease. So I went word for word, so it decreases what I asked for before to make sure I'm totally aligned. Although listed in the RUSP, each state then decides which diseases to add to their newborn screening program and which ones to leave off. At this time, 11 states test for Krabbe disease. Bear in mind, they put the Krabbe on the list before the federal recommendation, and 4 other states have passed legislation for screening or have a pilot program. Maryland is not one of them. For many years, advocates and legislatures have asked the Maryland State Advisory Council for Hereditary and Congenital Disorders to consider adding Krabbe disease and the infantile Krabbe disease to the state's newborn screening program, but we've been unsuccessful. It is important to note that Kennedy Krieger here in Maryland is nationally recognized for their work in leukodystrophy, and surgery and operations are currently being performed at Johns Hopkins University. Although Maryland will now be required to consider the inclusion of IKD to the newborn screening program, the council can decide not to add the disease. One of my issues is this with doctors. We all have doctors with different specializations, different skills, different knowledge bases, etc. In the case of these review processes, these diseases and others can be dragged out for years by the council. I have examples where RUSP has been approved of a testing disease, yet Maryland is still in acceptance. One of these is about 8 years old right now. I get it from a defense point of view. Everyone has to have their X in the box. Everyone wants to have their opinion noted, and we have to sign off on things. When I watch how budgets and things like that work, I know that you have to fudge a budget to get the increase in the cost in order to get the number you need to get to the recommended result, for lack of a better word. And everyone has probably heard of the $500 toilet seat in defense. And we know it didn't cost $500 to put a toilet seat onto an airplane. I get it. However, the longer it takes, the more babies die. And this is just wrong. It's our intention to have infantile Krabbe disease added to the list without years of continued pushback, as we are seeing this with ALD, which was put on the RUSP list in 2016 and is yet to be included in Maryland's newborn screening panel. Without early testing, the window to change a child's life through stem cell transplant is missed. Maryland families need to have every chance to raise their children with the best available health care. Let's give it to them. And I ask for favorable consideration for HB 96.
Thank you, Delegate. And who would you like to go next, please?
Steve, you want to go first? You want to go first? You go first.
Sure.
Ladies first.
Hi, my name is Kathleen. I am the mom of 3 wonderful children. My youngest child was born in Leonardtown, Maryland at St. Mary's Hospital. We brought her home. Everything was good. All the tests were normal. She could hear. Suddenly, she started crying a high-pitched cry. She was in pain all the time. Something was wrong with our little tiny baby. She was about 5 months old at this point. We took her to the doctor. He said I needed to see a developmental pediatrician. I called them all. There were months of waiting. I had a friend who said, take her to Children's National, which I did. Long story short, I showed them videos of her holding her head up, her being able to do things she could do, and then suddenly she couldn't do any of it, and they could see that. They rushed her back for a CT scan. She had white matter on the brain. From there, they wanted to do a sedated MRI. They found out she had Krabbe. It's this horrible disease that there was nothing they could do. They said, basically, take lots of pictures. She won't live to her 2nd birthday. She will have uncontrollable seizures, and it will be a very painful death. They'll try to keep her as comfortable as possible. We didn't like that outcome, so we researched and found out that NIH was conducting some studies in Pittsburgh. We drove out to Pittsburgh. Dr. Escalar was able to repeat tests and find out that she was eligible for a transplant. She could preserve her vision and her hearing, which were the 2 next things she would have lost. So with that, her dad and I, we prayed a lot, and we decided, you know, this is what we needed to do. We would regret it if we didn't. So we went through stem cell transplant, and Lily, I'm proud to say, is 12. She is an amazing little girl, but because I'm in Maryland and she wasn't tested at birth, she's not standing beside me. She's sitting beside me. She'll never run on the playground. She'll never dance at her school dance, but she's here. And she can smile, and she can listen, and she can hear me. We know families that have lost a child, transplanted a child, and their child is normal. You would never know they had Krabbe. Early detection is key. I pray and I hope that because I live in Maryland and I love Maryland Pride, that we can continue to test for Krabbe here in our state, my home state of Maryland, that I'm so proud of. Please.
And I want to say on behalf of the committee, thank you for coming and for speaking with us. I know it's tough to share, and I hope and pray that she recovers, that we can do something in the future, right? With research, because you never know, right, with all these illnesses. But I hope that your journey, that God gives you comfort, and thank you for sharing it with us, okay? Because it matters, and I know it's really hard from you, okay?
Thank you.
We just, the bill before you was talking about research, right? And we need to do more on that. My daughter works at NIH, and she's actually working with the Institute of Children's Health, and they're working on this disease is one of them. So you're in my prayers, okay?
Thank you.
Who would you like to go next?
You'll go next.
Good afternoon, Chairwoman and members of the Health and Government Operations Committee. My name is Ben Smith, and I'm here not only as a father of a child that is affected by Krabbe, but also a former voting member of the State Advisory Council on Hereditary and Congenital Disorders, which is an advisory council for the Secretary of Health. I'm sure you're aware. My experience with Krabbe began when my daughter here, Lily, was born and diagnosed in March of 2012 at 4 months of age at Children's National. We were told not to Google the disease, but to go home, take lots of pictures, and start planning a funeral for our 4-month-old child. As soon as I read the diagnosis from the prognosis on Google, and that other states were screening for this condition, my immediate response was to reach out to my legislators to help me understand why and how this could happen, that our children, my child, could have been missed. Only one of our
legislators responded to me, and that was Delegate Tony O'Donnell. He drafted a bill, but it was killed on scene die in 2012 by my very own state senator because his name was not on it. He admitted to me later that night that it would pass next year, but not this year. It'll pass next year with my name on it. So the next year, Delegate O'Donnell attempted to resubmit the same bill and was received some opposition to it because of through the speaker via the Department of Health. They said that there was a process and we needed to follow that process.
Take your time.
That we needed to follow that process. Well, we followed that process. I attended 2 years as a non-voting member of the advisory council and then was appointed by Governor O'Malley to the council. And I served 2 terms on the board. And what I saw was a very ineffective and very confused advisory council. Half the time we would meet. So we would meet 4 times a year. Half the time members would not show up and we didn't have a quorum. So we couldn't do anything at all. And other times the meetings would just be canceled altogether and postponed till the next time. So this advisory council is charged with all of the newborn screening for the state of Maryland, and newborn screening, I'm sure you're aware, is developing greatly at a speed more than it has ever been seen in the past. So, but they're only dedicating 4 2-hour sessions a year to all of that newborn screening. And like I said, half the time they don't show up. I presented a package to them that would include 6 leukodystrophies that could all be screened together. Krabbe was one of them. The advisory council decided to split those 6 up into individual diseases and examine them one by one. And you can imagine how long that took because they're not attending the meetings. We didn't have a vote, and it just kept pushed to the next meeting. Eventually, we did get through all of the disorders, and they were all added except for Krabbe. And I feel like there was a lot of misinformation that was being passed around. In one case, one of the members of the council said that infantile Krabbe disease is the least affected Krabbe community, but that's actually opposite. Infantile Krabbe is the most diagnosed of all the Krabbe. So you have infantile, and then you have adult onset. Adult onset is very rare, whereas infantile is very common, and much more deadly. So the council would often take a stance of adding diseases that prove to be clearly on the way to be added to the RUSP, but then other times they would oppose diseases that had already been added to the RUSP. And I never understood that if diseases are added to the RUSP by the federal side, we should be adding them in the state of Maryland. A lot of that has to do with just the process and the ineffectiveness of the advisory council. Another aspect of that I brought to the council was that the funds that are used for newborn screening should remain in the newborn screening program, and we passed a bill back in 2022 that guaranteed that the monies that were collected from the families for newborn screening would be reallocated to newborn screening. There's just
ask you to wrap up.
Sure.
Sorry about that.
I ask for your support for House Bill 96 and for the children yet to be born in our state. Thank you.
Thank you. And thank you so much for your service. Yes, next, please. And again, we're really sorry about what you're experiencing, okay? Go ahead.
Good afternoon. I'll be very brief. So my name is Brian Stone. My wife and I, Jessica and I live in Lexington Park, Maryland. We are Lily's aunt and uncle. On Monday, I submitted written testimony talking about the day-to-day life of Lily and all the care that is needed to take care of Lily. I just wanted to add on today, Lily has had a great year, been healthy, for the most part. But the past 12 months, Lily has had a spinal fusion surgery, which has required 6 or 7 trips to Pittsburgh Children's Hospital, which resulted in 35 to 40 nights to where Kathy, the mother, and other family and friends have had to stay over. 8 different family and friend members have stayed over to assist and for support for Lily. Again, she's had a great year. She had her 12th birthday. She celebrated her 12th birthday in Pittsburgh Children's Hospital. It's her 3rd birthday that she celebrated in the hospital. Her 1st and 10th also were in a hospital. So I just ask that, take a look and pass this based on RUSP. Because as Kathy and Ben have talked about, diagnosing this early on, Lily would have a very normal life if she had been screened early on. So thank you for your time.
And thank you for making time and coming here to talk to us. We really appreciate it. I'm going to open it up for questions now. Are there any questions for this panel? Actually, it's your first time on this committee, right?
It is.
All right. Are there questions for him?
Thank you very much. Y'all just, I'm a big boy, I can take it, okay?
Okay. I did see first Delegate Hill, then Delegate Bagnall. Yours is that.
First of all, I'd like to thank the family for being here and for continuing to advocate, not just on behalf of Lily, but on all the other people as well. Full disclosure, I'm currently on the Hereditary and Congenital Disease Committee, and I will say that I would like to let you know that the way it functions now is very much different from your experience. So we meet every month. Quorum's not generally a problem. And there is clearly a rubric and a deliberate process. So I just want you to know that it doesn't continue to function the way it did when you were on the commission. Delegate.
Yes, ma'am.
It seems like, and even the favorable note from Kennedy Krieger, and it points to the fact that there is a process now, which we didn't really have a good process before. And a lot of it has to do with the bill that was passed in 2022 that requires the advisory council to look at anything that the RUS passes. And it seems that the arguments that are being made might be better served in front of the advisory council rather than legislating or trying to get it onto our screening through legislation, in which case we would have literally dozens, if not hundreds of bills every year, asking for us to make decisions about what should be included and what shouldn't. Can you just address why do you think this is the better format rather than going through the process? That's
The logic I use, again, not being a doctor such as yourself, as if the feds can figure it out, I don't know why there should be a double review. Maybe there's a great reason for it. When I had spoken to the committee, I just think that there, as I said, different doctors have different specializations. I don't know what the specializations are in Maryland versus what the federal specializations are, but I do know different opinions can arise as a result of that. And when I look at, a couple of the bills, a couple of the other diseases that have been brought forth, I mean, I can't figure out why. I'm trying to find my cheat sheet here. I can't quite figure out why it takes so long, particularly in Maryland, which is a very progressive, great state for medical care, to basically say, well, we're going to wait a long time till we get the disease put onto the Maryland RUSP list when the feds have approved it a long time ago. I mean, like I said, this is a brand new world to me, and I'm learning day by day. Welcome.
Thank you. And there's so many diseases, you know, but if I know when the department comes, I'm going to ask, because the federal government now has done it, right? And I know their testimony was actually put in before they wrote the testimony before the decision. I'm going to ask them, would they look at it and change it? So when they come on, I'll ask that question for you.
Thank you, ma'am.
My pleasure. Anyone? No? Delegate Bagno.
Thank you, Madam Chair, and thank you for your testimony. And I've been taking a lot of notes. I know 11 states already do this. It's been added to RUSP since 2016. And whoever is best equipped to answer this question, I'm sorry, it's very sensitive, but I think it's important to get on the record. The cost and process of the testing versus the cost, not just financial, but emotional cost of long-term care without early diagnosis and intervention.
And this might be a tag team answer. You guys can probably describe better the financial and emotional costs that you've been through.
So the financial cost of adding this, based upon the cost estimate that I saw, was $15 per test. So at 75,000 bursts per year times 15, you're looking at just over 1 mil.
But what is the cost to you?
The
The bottom line to you, your family?
cost that Lilly has cost the state of Maryland is well over that, times probably 50.
And then every time she's
So-
in the hospital, you have to stay with her, right?
Right.
That means you can't go to work,
Right.
correct?
Yes.
Okay.
So if I can continue the question, Delegate, is that, and I'm reading notes that I have taken in, I try to say these words, I'm gonna butcher them, so. When they do the test, you have basically the HEAL test. And they test for something called gout. We'll call it gout because I can't say the rest of the word. And that costs basically, the machine needs to be told to do the IKD test, and it costs about $1. And then it goes to, if it's a positive, then they can go through another process and it can go send it to the Mayo Clinic for testing, and it can be confirmed in a matter of days along the way. I did look at I'm more of a finance guy, to be honest with you, the fiscal note for this. And right now, newborn screening panel for Maryland consists of 61 diseases, and it costs $106 per baby with the cost paid by the insurance of the parents. There's a proposed increase, we all know about fees, of $15.55 a baby going into the next year. So I'm not going to say this is linear, that it's going to cost $15.55 to add Krabbe, but fees are fees, and I'm just sort of dumbfounded by the numbers. I then look at the fiscal note that's been provided, and it says they need $874,000 to pay for the machine, yet the laboratory is required to screen for these diseases, and then it goes on to sit there and say that we're going to get the machine, but we need 3 more people. So it's amazing to me that we're going to do 1 more test and get 1 more machine. We need 3 more people to be able to do it. And it says here in the fiscal note on page 3, the laboratory administration activities intends to increase the fees by $12.26 to cover average annual increased costs associated with this bill, as well as a sustainability fee of $3.29 to cover unforeseen newborn screening procedures. I went to Maryland Matters, October 23, and there's a great article about the state laboratory celebrating 125 years of disease surveillance environmental testing, and it was for the Maryland Public Health Laboratory. Page 4. In 125 years later, the Maryland Public Health Laboratory now has an operating budget of $52.3 million. It's conducted about 9.3 million tests in 2023 for a variety of needs such as newborn screening, environmental chemistry, environmental microbiology, public health microbiology, immunology, and molecular biology. So I think that, the money's out there somehow. And I think it's there. I don't know if I've answered your question, but I've given you a bunch of data.
Okay,
Yes, ma'am.
thank you. I think, that you answer her question. And basically it's very little to pay for what it would cost and the impact that it has had on your family, right?
Right.
Right now, like she's sitting in the chair, she's not standing by you. And it's early detention and prevention, which we do a lot of that in this committee. I just texted my daughter to make sure this was the disease they're working on. And she said they're working on a neurological, very similar, disorder, in the Institute of Children's Health. And there's so many studies, right? And we hope that they can find a solution. But meanwhile, this is something that, is worth doing. And I know I usually don't say that, but, especially if the federal government has done it, I think when the department comes, I just want them to be ready to change the testimony for me and try to look into it. I want to say thank you so much for sharing your experience. It really matters. I know we have other people that I'm going to call to testify, but I want you to, just know that we're going to consider everything you stated, okay?
Madam Chair, thank you.
My pleasure. I know we have next, one
So,
second.
ma'am, I think we have a virtual.
We have
Melissa.
a virtual Melissa Shoemaker. And we have a question from Delegate Shalega, so I'm gonna call on her next. Thank you. Delegate Shalega, go ahead. I didn't see your light.
Thank you, Madam Chair. I just put it up because I had a thought, Delegate Morgan. Perhaps you could ask the bill analyst to relook at that fiscal note. I've had them do that before.
Okay.
So I think your data and math, being a finance guy, works, and I think their fiscal note is overstated.
So
Thank
if
you.
I could add to what Delegate Morgan said about the physical note. As a member of the advisory council, I was privileged to a lot of the knowledge of the ins and outs of the laboratory, the state laboratory. And it's been well documented in the past that they are underfunded and underpaid and undermanned. So these 3 people that they're asking for with this is just to fill a hole that they've always had. This is not to run the test. They just need 3 people, and they've needed three people and a new mass spectrometer for a long time. But they're trying to tie it to the funding for this bill.
Thank you. So I'm going to go to an unfavorable panel and then come back to the virtual witness, okay?
Sure.
And for the committee, thank you for allowing me to be flexible, a little flexible with this hearing, okay? Thank you so much. We're gonna
Thank you,
call an
Madam Chair.
unfavorable panel. Thank you. And next, I'm going to call the Maryland Department of Health. Shelley Shu, we're gonna call the Mr. Jamie Frazier from the Maryland Secretary Advisory Council for Hereditary and Congenital Disorders. And then we have a virtual unfavorable, actually, there will be the third person. Is there someone else? There is a Jamie Frazier. She's virtual? Okay. All right. So I know you're about to testify. So you heard the testimony. And the fiscal note states that the federal government has already added. Usually it states in the fiscal note, it says on January 30th, the U.S. Advisory Committee on Hereditary Disorders. Wow. There's some words that I have a hard time in English with my Spanish, but heritable disorders in newborns and children voted to add infantile Krabbe disease, right? And it says that Maryland is one of those, page 4 of the fiscal note, it states that approximately 12 states, including Maryland, as discussed earlier in this analysis, have an RUSP alignment policy under state law. Many of those states may add Krabbe disease to their newborn screening programs in the upcoming months or years. And I know that usually you follow it. So my question to you is, can you please go back, given that your testimony was submitted before this decision, and consider doing this without the need of this bill?
Good afternoon. My name is Shelley Chu. I'm with the Maryland Department of Health, as noted as well, too. Thank you so much, Madam Chair, for bringing that up as well, too, because the Hereditary Statewide Council, there was legislation passed in 2022 where they have to review any condition added to the federal recommended uniform screening panel or RUSP within the year. As well, too. So I just also wanted to give some additional information as well, too. So now that the heritable disorders in newborn and children on the federal level voted to recommend adding in Krabbe, then HHS Secretary will also formalize to add Krabbe to the RUSP panel as well, too. I wanted to share that information along with also addressing with the advisory council, too, that last year they met 9 times. They recently met January 31st with another meeting for February 14th as well, too.
So since the heritable disorder, and I got it right this time, made the decision, and they're meeting in February, we're here until April 9th. I like for the council to please take this on and review it. Because we adjourn on April 9th. And I like to be able to get it done without the need for with a bill, if at all possible. What date are they scheduled to meet in February?
February 9th.
February 9th? Okay, that's around the corner. That's in 2 days.
I just and I can follow up just to confirm too with the date too. But thank you as well too. I think I had February 13th as well too. So but we'll follow up.
So can I ask you, can you let me know the date? Can you call my office?
Yeah.
And then can you please bring it up and see if it's at all possible? And let me know by next week, please.
All right.
Okay? I really appreciate it. I think that everything can be aligned to work on something here. And oftentimes we don't need a bill if the department can do it, right? And especially since the federal government already made a decision. Okay?
All right.
And I thank you. I know it's not easy to come after, the testimony that we just heard. So I thank you for being here and for working with us. We also appreciate your services and your work. Okay?
Great.
Thank you. Any questions? All right. Thank you so much. You have a blessed day and I look forward to hearing from you. And let me know how we may work to help you out as well. Okay? Thank you. So we are going to go to virtual. Will you be so kind, please, and bring the unfavorable virtual panel? Thank you. And then for the committee planning purposes, we have one more favorable witness left after the favorable panel, okay? And for your planning purposes also, we have 2 bill hearings left. Good afternoon, ma'am. How are you?
Hello, good afternoon. I'm well, thank you.
Hi. Will you please tell us your name?
Yes, ma'am. Thank you for the opportunity to speak with you today. My name is Dr. Jamie Fraser, and I am a Maryland resident, a board-certified medical biochemical genetics physician, and I currently serve as the chair of the Maryland Advisory Council on Hereditary and Congenital Disorders.
Okay, and when do you meet? When is your next meeting?
We next meet on February the 13th at 5:30 in the afternoon.
Okay, so February 13th at 5:30. So you heard the testimony before you came on, right?
Yes, ma'am. I have heard the testimony as it has been presented, and I am also a leukodystrophy physician. I direct one of the leukodystrophy programs that cares for children in the state of Maryland.
So I have asked respectfully of the Maryland Department of Health to get in touch with your board since your meeting, and ask if you will be so kind to please review this bill and this screening for this disease, so that we don't have to pass a bill. Oftentimes you can get it done without a bill. And if you can please take this under consideration. This has been in front of us for many, many years. And now that the federal government has actually recommended it, and Maryland usually follows that recommendation, the committee would ask respectfully that you take this under consideration on the 13th.
Yes, ma'am, and I appreciate the question. I think there needs to be additional clarification as to what has actually happened with the conversation around Krabbe. The Secretary of Health and Human Services has not actually formally added Krabbe disease in any form to the recommended uniform screening panel. The advisory council to the RUSP, which acts just like our Maryland Advisory Council does, has made a recommendation, but their recommendations have not been finalized. The documents have not been clarified, and there is still lingering lack of clarity as to the targets of that screen. And so so it's not technically formally added to the RUSP yet at this time.
It's not added, but it's recommended, and there are currently 11 states that actually screen newborns for this disease. I mean, this is going to happen, right? And it is going to happen. That is where it's going. That's where the dominoes are falling. So I'm asking you to please consider doing it, because we're going to see this bill every year, and there'll be children like the one we just had that is missing an opportunity to be diagnosed early, where early prevention on every disease and illness that this committee actually looks at makes a difference, right? Whether it's cancer, whether it's diabetes, right? And the odds of living a fuller life, it's a lot better when it's early. So I'm just asking respectfully, will you please discuss it on the 13th?
Yes, ma'am. We will bring it up again for discussion on the 13th. We have been a part of conversations about Krabbe newborn screening for multiple times over the last few decades. I have not been on the council the entire time, but every time we've discussed Krabbe, there have been lingering concerns about the well-being of other children in Maryland who actually are not diagnosed on the screen, but are false positively screened. And there are additional costs and risks to those children that are not insignificant. And so we await the RUSP for final decision making, because there were specific restrictions placed on the limits of that screening for Krabbe specifically that have never been put in place before by the advisory council at the federal level. It's
So
more
what I would need-
complicated. It's more complicated than
Right.
typical.
So because it's complicated, and I know it is complicated, and it can change, what I would need, right, since we have a bill in front of us, is that a commitment from the Maryland Department of Health that once those recommendations are final, and it tells you unrestricted to whatever population with whatever guidelines, then Maryland will do it. If they give me their word, then we know that we don't need the bill, and that I trust this administration, and I know that they will keep their word. So that's all I'm asking for. And Ms. Shu is here listening, and Ms. Crum as well. So they know exactly what I need make sure that we take care of this bill here. Okay?
Yes, ma'am. I will say the council does not report to the state of Maryland. We advise the Secretary of Health. We are not employees of the state of Maryland. And so we provide our evidence-based guidance as expert physicians, lay people in the community with an investment in public health of all children and humans in the state of Maryland. And we give our best evidence-based and consider guidance. And once my testimony is complete, I'll be happy to address any other questions that may arise from it.
That sounds good. And I appreciate your role, because a lot of times this is volunteering, but I think the fact that 11 states do it, and that is now going to be a recommendation, it is the way, I've been on this committee for 17 years, and I know when things are moving, and it's going to come to that. So I'm asking for the consideration. So go ahead.
Thank you.
You're welcome.
So I'm here to testify in opposition to House Bill 96, which would add Krabbe leukodystrophy to the Maryland newborn screening panel by legislative process. For those unfamiliar with the newborn screening process, every baby born in the US receives a heel prick and a few drops of blood are added to a piece of filter paper, which is sent to the laboratory. Those few drops of blood are used to test for around 50 conditions. The exact number varies by state. In Maryland, the conditions screened for are determined by the Secretary of Health through recommendations by our council. The council spends hours weighing available peer-reviewed scientific evidence, consulting with outside experts as well as Maryland resident experts, and thoroughly reviewing the potential harms and benefits of each screening test before reaching a decision. For the council to recommend adding a disease to the newborn screen, the condition must not have obvious signs and symptoms detectable in the newborn period, must have accurate and reliable screening and confirmatory diagnostic testing methodologies, and must have an available, effective, and accessible treatment. The council has developed an objective assessment to consider these factors based on the American College of Medical Genetics recommendations for newborn screening programs. The decisions made by the council are not made lightly. The council includes medical experts in genetics, pediatrics, neurology, and community medicine, community members, including those impacted by hereditary and congenital disorders, and Maryland legislators, each of whom has an equal voice. With all due respect to the legislative process, the considerations, evidence review, and discussions surrounding the addition of a condition to the newborn screen in Maryland require more than the 2 minutes of testimony that I have available to provide. In 2022, the Maryland General Assembly passed legislation that requires the council to review any condition formally added to the federal recommended universal uniform screening panel, or RUSP, within a year of its addition. Review of the available council data from all conditions added to the RUSP that have been reviewed and evaluated by the council, for which we have minutes, have subsequently been recommended for addition to the Maryland Newborn Screening Panel. Occasionally, the council has been approached to consider conditions that were not on the RUSP. In those circumstances, the council has not recommended addition of those conditions to the Maryland Newborn Screen because they had not achieved the threshold of evidence.
You can continue. Go ahead.
Thank you. Last week, the federal equivalent of our council voted to recommend addition of the infantile Krabbe leukodystrophy to the RUSP. If the Secretary of Health and Human Services, Secretary Becerra, adds Krabbe to the RUSP, our council is mandated to review it. If for any reason the council did not recommend approval to the panel, we would continue to review it annually per the legislation. Finally, funding the Maryland Department of Health's laboratories and follow-up programs is essential to support newborn screening in the state of Maryland. Sufficient budgetary support for hiring and retaining the skilled laboratory scientists, PhD and fellow trained laboratory directors, public health professionals, and follow-up nurses is critical to timely implementation of any new condition added to the newborn screening panel. I appreciate the opportunity to speak with you today. Our council takes its charge seriously, and we hope that you will continue to allow the council's process, which has been in place for over 40 years, to thoroughly evaluate, analyze, and discuss the addition of each condition considered for Maryland's newborn screening panel, based on its evidence basis and the public health benefits to the citizens of Maryland.
Okay, thank you. And thank you for your testimony. And of course, you will continue to do your work. I know that this legislative body passed a bill, that required the council to follow the recommendations of the advisory committee on, heritable disorders, because they weren't doing it. And it's not you, because you haven't been there that long. But that's why the legislative body had to get involved. But now that, you guys are doing the work, we thank you, because I know that it's a lot of work. We do not take it for granted. But given that this is going to be added, we just ask, since we have this bill, we're only in session for 90 days. And that's sort of like the big elephant in the room, right? And you have the families coming, every year. If you could consider it on February 13th, okay?
We will bring it back up.
That the guidelines, you have to follow the guidelines. I know that. As
If
well.
I may add, as a leukodystrophy physician, I have taken care of children with Krabbe disease many, many times. I have helped those whose families sought transplant to get to transplant centers who are transplanting Krabbe leukodystrophy. I've also helped children who were so ill by the time they got to us that they did not have a benefit of transplant because they would have died from it. I've helped them pass away comfortably from their disease. I understand and have experienced myself the grief and agony of losing these children to Krabbe disease over and over. We don't dispute the validity and the importance of this disease. The issue is that there are risks to children who do not end up having a diagnosis of Krabbe disease, but do screen positive, and they are significant and invasive. That's the first issue. The second issue is with respect to the timeliness between addition of a disease to the federal RUSP, addition of disease to the Maryland newborn screen, and implementation in the laboratory. I think the condition that Mr. Smith was speaking about previously was related to X-linked adrenoleukodystrophy, and the fact that it took 8 years to go from being added to the Maryland newborn screen by our recommendations to implementation in the laboratory. And that in fact did have to do with funding in the laboratory. The laboratory had to have an additional mass spectrometer to run that assay. These are multi-million-dollar machines. You have to have exquisitely trained personnel with the expertise to not break multi-million-dollar machines. And those folks are harder and harder to come by at the state level because they're being reimbursed and compensated better in private sector. And it has taken a long time for the lab to staff back up over the last 3 to 5 years from where it has been. They are finally staffed up for all the disorders that are on our screen. And if Krabbe were to be added, as an outside individual who's a medical biochemical geneticist who understands how these tests are run and how they are analyzed, the cost estimates are likely accurate because these machines are exquisitely expensive, and it does take more than one person to run those machines and to perform those screens. The state lab works diligently and constantly. We get calls every day of the week for critical newborn results. These machines take more than one skilled person. And I appreciate the fact that this hearing is happening because I think newborn screening in the state of Maryland deserves a lot more attention, but it also deserves a lot more financial support from the legislature if these things are going to be done in a timely way.
And that's why we talked to the Department of Health, right, before you came on, and we're talking to you. And I know that it's expensive, but it costs so much more to treat a child. And then the physical and the emotional, as you know, because you deal with these kids. I'm a lawyer. I'm not a doctor. So usually lawyers, we complicate things. But I can tell you that the emotional trauma they go through, you can't put a price on that. So we're just trying as legislator in an honest way, asking respectfully, given that you are meeting on the 13th, given that we have the new order from the federal government, given that we're only in session until April, if you can find it in your heart to discuss it and maybe make the recommendation, work with the department and see if we can find a solution, because we're going to find ourselves back again in this situation next year. So thank you for being willing to listen. Thank you for your testimony today. I know it's very frustrating, right? Because it comes down a lot of this to funding as well. So I thank you for your service and for your time this afternoon. Okay.
Thank you, Chair Payne-Melnick. And we would be happy to see you on the 13th if you're available to hear the conversations that we have about Krabbe.
Absolutely. If I'm not in hearings, right? Because I look at the time, it is
I know
13 and I'm still here. So I doubt it highly that I'll be with you because we have 62 more days left in session. But I'm sure that if it's recorded that I'll watch it in the evening and I can do that. Okay. Thank you so much. You have a blessed day.
Thanks, you too.
You're welcome. All right. You have a question? Who has a question? Delegate Alston has a question. Oh, did she leave? She left. Sorry. It's okay. You can go to the hearing next week. Maybe one of you needs to go to the hearing, and I apologize. I didn't look that way. Yeah. So if you could go to the hearing, miss this. I'll give you a pass. Okay.
I think we lost Dr. Fraser.
We did. We lost her.
Okay.
Okay.
I don't know if anyone.
You want us to see if we can get her while we call the next witness?
Yes. Well, I think others have questions. I'm not sure if they were for her, but my questions were for her, anyone else who has that level of expertise.
Yeah. So she's gonna call her.
Okay.
Okay, so let me call the next witness, okay? Just
Okay.
hang tightly.
No problem.
All right. Melissa Shoemaker, can you call her? She there? Okay.
Hi, can you hear me?
Yes, good afternoon. Will you please get started?
Yes. Okay. My name is Melissa Shoemaker. I am here in support of House Bill 96 in hopes of a favorable outcome. Our family has been directly affected and forever changed by early infantile Krabbe leukodystrophy and by the lack of testing newborns for Krabbe in the state of Maryland during the initial newborn screening. Our first child, Parker, passed away from Krabbe at the age of 10 months. He was deprived of opportunity for life-saving treatment by being diagnosed at 4 months of age versus at birth via newborn screening. Although not a curable disease, there is successful treatment through cord blood transplant if diagnosed prior to the onset of symptoms. As first-time parents, we lack the knowledge of available options of supplemental screening tests and assumed Maryland tested for treatable terminal illnesses at birth. We were not given the choice to treat our son as he was ineligible due to being symptomatic at the time of diagnosis. I have personally met children that were born with early infantile Krabbe disease who were treated as infants and are talking, laughing, walking, and living all the wonders of an ordinary, normal life. It is heartbreaking to know that our son could be among those treated if early detection was available to us in Maryland. Our hope is that Parker's legacy and story will help save future lives in Maryland. Knowing that this bill could save a family the pain and suffering of the wisdom discovered too late, the months of not knowing what is wrong with their newborn, and the inevitable deterioration and loss of life. My ask today is that the committee take into consideration the addition of Krabbe to the newborn screening panel, knowing there's life-saving treatment available, that the capabilities and science are already available to the state, and the recent decision from the Federal Advisory Board to add Krabbe to the RUSP. Knowledge is power, and we strongly advocate for parents in Maryland to have the education of early diagnosis. Thank you for your time and careful consideration.
And thank you so much for being with us. And we do have Dr. Frazier. She was actually in the waiting room. So let's go back to her. Thank you very much. Can you bring Dr. Frazier, please? Is she in? Dr. Frazier, thank you.
No
Thank
problem.
you
I'm
so much.
sorry.
It's okay. So thank you for your patience. We do have a couple questions for you since you're an expert on this. We have the first question from Delegate Kaiser, and then Delegate Alston, then Delegate Taveras. Delegate Kaiser.
Thank you, Madam Chair, and thank you, Dr. Fraser. And with the delay of losing you and having you come back, I had enough time to get an answer from my brother, who's delivered over 1,000 babies and is now a neonatologist, that he's never heard of this. So little surprise. Anyway, so I'm trying to educate him right now. So my question for you, when I was listening to the testimony you were providing, I guess I wanted a sense of how frequent a diagnosis this is, but you also mentioned that the false positive could have disastrous impacts for families. So I wanted to get a sense of, when you said we have 50, and I'm sorry, Madam Chair, this is a longer question than my
It's
usual.
okay. I took a long time, which I never do. So thank you guys for being flexible. Go ahead.
When you mentioned that about 50 conditions are currently tested and that you do the one that you've put the ones in that have a good test, I was wondering what the appropriate false positive and false negative is for a test that you've allowed. And then again, what is the problem with this test that it's not accurate right now? Is it giving too many false positives, false negatives, or both?
It's more about the surveillance required of children who screen positive without a clear diagnosis of early infantile or infantile Krabbe disease, which requires urgent and immediate transplant. So there's the first part. I'm going to try to break this down because it is complicated on multiple levels. We have about 1 to 2 diagnoses per year of Krabbe disease that we care for in our hospital center. I am not speaking on behalf of my employer. I'm speaking on behalf of myself and as the chair of the council. We provide referral care for individuals whose parents choose to pursue transplant for Krabbe disease. There are very few centers in the country who are comfortable and able to provide the timeliness of transplant required for early infantile Krabbe. So we want to make sure that when those children need to be transplanted, we can get them to transplant if that's what their parents choose as fast as possible. For children who are not diagnosed early enough and progress from their disease rapidly, or whose parents choose to forego transplant because of the long-term complications of transplant after symptomatic disease, we provide palliative and supportive care with our multidisciplinary team. The problem with the screens as they are right now is that, number one, it relies first on the GAL-C activity as the first measure, which is a typical way to start a newborn screening process. If that activity is low, there's a recommendation now to reflex to a biomarker called cyclozine. At the current recommendation to the Secretary of Health and Human Services, that recommendation the vote from the Federal Advisory Council recommended that the cutoff for cyclozine be greater than 10. As far as I'm aware, there has never been a set cutoff process made at the federal RUSP level. Those cutoffs are usually established by the state labs or the contracted entity with which they work. So this is a very atypical setup in the first place. The reason that cyclozine was added as a second tier recommended test on the newborn screen is because the GAL-C activity itself is unreliable as a primary marker alone. Because many people out in the world have specific differences in their proteins that do not cause disease in their GAL-C proteins. But when you look at that protein in the laboratory under the settings and the experimental conditions, if you will, or the test conditions that we use, that activity appears to be insufficient or deficient. So the activity is too low and would be the first flag as an abnormal screen. At the time when we last reviewed Krabbe disease for the newborn screen in Maryland, the data on cyclozine as a second tier test was not fully established and well elaborated to justify the discussion of addition of Krabbe because the cyclozine data was too new. And there weren't enough data points to say whether it was informative or not. So in the subsequent years, the states that have added Krabbe to the newborn screen have largely added it by legislation outside of the normal recommended circumstances by which we operate, which is under a panel that advises the Secretary of Health. And that has been done with advocacy support from families who are devastated, obviously, by their children's diagnoses. The issue is that when we think about newborn screen, we don't only have to think about children who have the disease, but we have to think about every other child born in the state of Maryland who could screen positive for this disease, but not have disease and not actually need to go to treatment. The surveillance and the sort of disambiguation of a positive screen for Krabbe is markedly more complex than are the bulk of disorders on our newborn screen. Because most of those disorders require an additional blood test and usually genetic sequencing, and that is it. The recent experiences from states that have added Krabbe to the newborn screen, where they have used decreased GAL-C activity and an elevated cyclozine above 10, include folks in the state of Pennsylvania. In speaking with my colleagues there, they have had 6 babies who have screened positive in their center for infantile Krabbe under those set of circumstances with a low GAL-C activity and a cyclozine greater than 10. When you do the confirmatory testing for those babies, you have to get genetic sequencing. You have to get repeat cyclozine levels because as screens, these are not diagnostic tests and they have to be repeated. Usually those screens will go to Mayo. Those diagnostic tests will go to Mayo laboratories in that circumstance. Oftentimes we repeat the GAL-C activity, and then we have to also do at the same time a series of diagnostic evaluations in these newborns. And those include, per guidelines, a brain MRI, a visual evoked potential, which is looking at the brainstem's ability to see what information hits their eyeballs and process that. The auditory brainstem response, which measures the brainstem's ability to hear the sounds that are coming through the ear. And a nerve conduction study. And those nerve conduction studies are where needles are placed into the nerves of the leg or arm, and the potential or the electrical signal between those two electrodes are tested. Additionally, most places are also following this with a lumbar puncture to evaluate cyclizine and other metabolites in the spinal fluid. So that's a spinal tap. So for Krabbe, we're not talking about simple blood tests and urine tests that we do for the bulk of the other conditions that we screen for. We're talking about markedly invasive follow-up and diagnostic testing. Like I said, in Pennsylvania, of the 5 or 6 children who were screened positive with secondary follow-up of those biomarkers, and having gone through all of that diagnostic testing, 1 child qualified for transplant. That particular center in Pennsylvania is one of the major transplant centers in the United States. That child failed to engraft their donated donor bone marrow twice and has gone on to progress with their Krabbe disease in spite of timely transplant with a very aggressive treatment team. In the meantime, those 4 or 5 other babies who were initially screened positive and may have a milder, later onset version of Krabbe disease that may not present until markedly later in life will have to, well, their parents face a choice. They either agree to undergo routine quarterly surveillance by all of the mechanisms that I just mentioned, the MRI, the spinal tap, the blood draws, the nerve conduction studies, etc. Or most families, according to my colleagues in Pennsylvania, tell me that they're choosing not to do all those because they're so invasive. And after the newborn period, these babies have to be sedated for those MRIs. And so sedation in and of itself carries a significant risk. And so the families are in this place of limbo where they are very uncertain about what their outcome for their baby is going to be. The screen itself is still not in a place to be reliable enough to pick up the early infantile Krabbe disease that the advocacy community is pushing for without having, 80% of the screen positive babies having a markedly longer course where they are medicalized excessively, imaged repeatedly, sedated, and anesthetized repeatedly, and having all of these tests on them to eventually perhaps maybe one day meet criteria for transplant. That's the first issue that has become an issue with why Krabbe is markedly more complicated than those other 50-odd diseases on the RUSP. Furthermore, the data from newborn screening in Krabbe disease that has been peer-reviewed and published over the last few years, which is more modern data than we historically have had, does not demonstrate that these children have markedly less disability and morbidity or long-term chronic health problems and developmental impairments than children who have treatment when they're symptomatic and are stable, but need to undergo things like spinal fusion, like Lily had to go through. And so when we don't have evidence past 30 months of age for these children, we don't know how much benefit they're actually going to get in the long term from this potential treatment. So that's the second issue. The third issue is an issue of accessibility and equity. So for the treatments that we have for the other disorders on the newborn screen, those, for the most part, those treatments are accessible, marginally covered by Medicaid, but as clinician providers and hospital systems, we make it work to support these families. But the places where we are having the most difficulty are with the conditions that require hematopoietic stem cell transplantation. I personally care for over 20 children with X-linked adrenoleukodystrophy, which was only recently implemented by the Maryland State Lab. It has been on our recommended panel for over 7 or 8 years. And the children who have the hardest time getting a treatable transplant to arrest their disease progression, save their cognition, and save their lives are children of color. Those children, we have years to find a good match for. In babies with Krabbe disease, we have days. And my transplant team, I'm not a bone marrow transplanter, but my transplant team tells me that finding accessible, safe, and effective donors in the amount of time that we would be able to achieve is very difficult, if not impossible. And we may be forced with sending families, as we have already done, out of state, out of Maryland, out of the DMV to get care elsewhere. That, of course, assumes that the hospitals that are providing that care are willing to take our state Medicaids. Most of the children in the state of Maryland with chronic disease have Medicaid. And that's not always a guarantee as to whether or not they'll be received at an outside hospital. So again, the complexities of Krabbe are markedly greater than those of just about every other disease on the newborn screen, with the exception of maybe X-linked adrenal leukodystrophy, but we have the benefit of time, protected surveillance, and markedly better screening and diagnostic testing for that disease than we do for Krabbe in the time we have to treat. Does that answer your question, at least the first part?
Okay. Who's next? Delegate Olson. Go ahead. Followed by Delegate Taveras. She got it? Okay, great. And thank you for your patience, Doctor. We appreciate it.
My pleasure. I'm happy to try to help answer these questions. I know they're complicated.
Thank you. Go ahead.
They are complicated, and thank you for your expertise. So my question is, in your dissertation just now, you indicated that you would have days to find a match for someone. Wouldn't it make more sense to have that screening done at birth so that if you only have days to find a transplant, that you're way ahead of the game, as opposed to months later when all hope may be gone for these parents? I think the choice should be within the realm of the parents, not the government, to decide whether or not to go through the testing if it's a false positive or not. And I think it's the parents that should be making the decisions on how they want to proceed with their child's care. But if as a state, we're not even doing the basic screening at birth, aren't we denying those parents the opportunity to make those decisions? Isn't that so?
I think it's a bit more complicated and nuanced than that. So first things first, about parents and their ability to make decisions. The newborn screen in Maryland is more of an opt-out than an opt-in. So the parents' consent for testing is often very limited, if given at all, to be blunt with you. The second part is, when I said there were days, that is actually related to newborn screening. So newborn screening is not instantaneous. It's done at a day of age, about 24 hours of life, and it takes somewhere between 7 to 10 days to complete shipment from the birth hospital through first and second tier screening and having results sent back to the hospitals where we provide care to children. So in that timeline, with all of the requirements that we need to be able to safely treat these children, even with newborn screening, we have 16 days, according to the guidelines, 16 to 18 days, if we're going to transplant them in under 30 days, okay? That's in the best case scenario in this perspective, in this concept. Personally, as leukodystrophy physicians, we have advocated for universal screening of pregnant people for these disorders, because frankly, if you could diagnose this in utero, we would have markedly even more time to be able to treat these babies and know that they are affected long before they're born. This takes marked, drastic levels of coordination of care that is nearly impossible without admission to a neonatal intensive care unit, and even in the best of circumstances, to facilitate transplant. If we had the genetics of this baby in advance, we could admit that baby upon delivery to the neonatal intensive care unit, proceed with confirmatory genetic biochemical and diagnostic testing, and have HLA phenotyping initiated within 1 or 2 days of life. That would be the ideal circumstance. Newborn screening actually doesn't serve these families as well as prenatal or preconception genetic carrier testing does, because that buys us months, not days. So I agree with you that families should make those decisions, but I also think that families should understand what risks come with a false positive. when 80% of all positive screens with the significant risks to babies who don't have this disease have enough risks to also possibly be life-threatening. There are, children can die under anesthesia. That's not hyperbole. And I think that, yes, families can make those decisions, but the trauma of false positives and uncertain screening is significant. For mucopolysaccharidosis type 1, we've had over 300 false positives in the state of Maryland for a single given true positive. And those families panic because they also read the outcomes and from these diagnoses, and they worry that their child too will need a bone marrow transplant in order to survive. And they don't. So while we talk about the possibility of an effective treatment, which has, again, lacks sufficient long-term evidence basis compared to the other diseases that we treat, we also need to remember that the parents who are having their children undergo newborn screening deserve the opportunity to know that the screen that their children are undergoing is reliable and it is effective, and their children are not going to be put at greater risk for a screen that they otherwise would not have.
We appreciate your expertise. And it's funny because when we sit in these committees, we're trying to make decisions, right, by listening to both sides, right? So we appreciate you very much. But while you were talking, I was looking online for some experts, and I found out that there's a pilot research program in New York that screen babies for 14 disorders that are not in the state routine panel, and that the doctors that are running that feel that, quote, that screening would allow more infants, even knowing the false positive, and babies, for example, with Krabbe disease, to get early, stem cell transplant and other things. So you try to weigh the options and choices. I also found out that the University of Buffalo actually received a $5 million grant for testing, and where their tests are more accurate as well. So we're making a lot of advancement regarding these disease as well. So I think that it is complicated, but it is moving forward. And some parents would argue that getting a false positive is better than not getting one at all, and then find out that your child has it and it's too advanced. So it comes down to choice, right? And the parents will probably, once educated and informed, will like to have the choice. But in any event, we know the federal government has made the recommendation. Hopefully they'll adopt it and Maryland will follow it. And you will discuss it on the 13th. And we have the bill in front of us. And we will talk as well. Delegate Kipke had a great idea to talk to the budget committee about perhaps putting money for this machine in the budget as well. So we will work it. And we thank you for your time and your efforts. Thank you so much for your knowledge and for sharing it. We really appreciate it.
Thank you.
You have a blessed day. Thank you. We have, is there a Carol Green? Yes. And that will be the last witness, correct? Thank you. And thank you everyone for your patience. Miss Carol Green? Is she on there? Good afternoon, ma'am. Hello? Miss Carol Green? Is she showing up? Miss Carol Green, can you hear me? Will you be so kind and get started? You are our last witness for this bill. Miss Green? Miss Carol Green, can you unmute yourself, please? And thank you so much for being patient. Will you be so kind and unmute yourself? Well, we're going to just move on, okay? Thank you. This is going to, can you let her know that we try to get in touch with her and to give us her testimony in writing, please, for consideration. We do read everything that comes to us, so we'll consider it. This actually concludes the bill hearing on House Bill 96. I want to thank everyone for your patience as we discuss this bill. Next, we have House Bill 177. hospital care of infants after discharge. I know she fell asleep. I don't blame her. I don't blame her at all. Would Delegate Lewis, can you please call Delegate Robin Lewis? And would her panel come up, please? And the panel for Delegate Lewis is as follow. Give me 1 minute. It is Brandon Scott, Nina Temelis, Katie Costa. If you're here, will you have a seat, please? And let's see if you can find Delegate Lewis. All right. Thank you very much. And thank you for your patience. And this is House Bill 177, Delegate Robin Lewis, Hospitals Care of Infants After Discharge.
Thank you, Madam Chair.
Thank you for your patience.
Thank you so much, Madam Chair.
And I apologize. I did not know that bill was gonna go that long, okay?
Please don't apologize, Madam Chair. That's our job to listen and deliberate.
Thank you. Thank you.
For the record, I'm Delegate Robin Lewis here on behalf of House Bill 177, Hospitals Care of Infants After Discharge. Let me also say for the record that one of the things about our job is that it's incredibly emotional, and we jump from high emotion to low emotion, everything in between, and that we somehow have to keep our composure and keep working for the people of Maryland. So right now, I'm doing my best to do that. I try to do it as well as you do, Madam Chair.
Thank you.
So I'm joined by my sponsor panel. Thank you. This is a bill that may be familiar to some. We've been trying for a few years to institutionalize safe sleep procedures, practices into our statewide healthcare system for a few years. I'm really pleased to say that I think we've hit the sweet spot, and we've developed a legislative proposal that is agreeable to stakeholders, implementers, and that will save children's lives. The bill before you, the bill language that you'll see in your floor system has been amended with the help and diligent, good faith efforts of all stakeholders, including the Baltimore City Health Department, the Maryland Hospital Association, the University of Maryland Medical System, LifeBridge Health, Johns Hopkins Hospital, and probably some others that I may have neglected to list. But we feel we have a strong bill. So this is what the bill will do. Basically, it will scale statewide an amazing and life-saving program that was developed in Baltimore City, the Be More Healthy Babies program, that is developed best practices for protecting infants from sleep-related deaths. Now, we know there are so many twists and turns and dangers in life, and things can go wrong. But wherever we can prevent an injury or loss of life, we do our best to lean in and make those preventive measures as widely available as possible, protecting infants from death due to sleeping, problems with sleeping, arrangements of their sleeping. It's so common sense, we should do it, but you'd be surprised. In the state of Maryland, in 2020, nearly 400 Maryland babies died in the first year of life. About 50 of those deaths were caused by sleep-related, and those sleep-related causes were almost entirely preventable. So a safe sleep practice is one that there's a principle ABCD that no smoking around a baby, no putting in soft pillows and things in the baby's crib, anything that they could potentially be suffocated by or prevent them from rolling over. You always put them on their backs. These are common, they seem maybe common sense, but common sense isn't so common. So we want to make these practices part of the practice that's offered by every birthing hospital across the state, modeled on this amazing Baltimore model, the Be More Healthy Babies program. A couple of things I'll add. The safe sleep practices that we'd like to institutionalize in every to educate parents and from who give birth at every hospital in the state. They are aligned with best practices developed and endorsed by the American Association of Pediatricians. So this is best practice nationwide. And we think we can do it. We think we can save lives. So with that, I'd like to thank you for your attention, ask for a favorable report. I can talk about the amendments that we've discussed, but we could also save that for subcommittee because I'm sure everyone is weary. But with that, I'd like, with your indulgence, Madam Chair, turn the mic over to my panelists. And I've got, I think I'll start with the City Health Department and then the Mayor's Office. Can we do the Mayor's Office and then the City Health Department?
Whatever you like.
Yes, thank you so much.
You're welcome.
Go ahead.
Good evening. My name is Nina Themelis. I serve as Director of Government Relations for Mayor Scott. I'm here to testify in support of HB 177 on behalf of Mayor Scott and the Baltimore City Administration. Unfortunately, Mayor Scott could not be here this late in the evening, so I appreciate being able to step in and speak on his behalf. First and foremost, this is one of the mayor's top priorities for the 2024 General Assembly session. I want to thank Delegate Lewis for bringing forth this common sense and straightforward bill. As many of you may know, Mayor Scott recently became a father in December of 2023. However, issues involving infant and maternal health are not new to him. Last year, with the help of this committee and with the help of Delegate Lewis, we were able to pass some meaningful changes to this Baltimore City's maternal mortality review team. And so this issue kind of couples with that in ensuring that we work to reduce maternal and infant deaths. This legislation would just help to ensure that all hospitals are required to provide proper safe sleep education to all new parents and provide them with resources concerning a safe sleep environment. Most hospitals already provide some form of this information. This would just standardize or make it mandated that all hospitals do provide this information. So we do think it is very straightforward and simple to implement. And with that, I just request a favorable report for HB 177, and our health department can provide a little bit more of the technical information.
Thank you for your testimony. Next, please.
Thank you so much for the opportunity to testify. My name is Kathy Costa, and I direct the Child Fatality Review Team at the Baltimore City Health Department and also lead strategy for the city's Be More for Healthy Babies initiative. Since 2012, I have personally reviewed 156 cases of sleep-related infant death that have occurred to babies in the city. And in all but 3 of these deaths, the baby was either known or suspected to have suffocated while sleeping in a hazardous environment where there may have been very soft bedding or sleeping with a caregiver who then rolled onto the baby. These preventable deaths are the leading cause of deaths for babies who go home from the hospital after delivery. And we have a responsibility to ensure that families, 1, know what a safe sleep environment looks like, and 2, get resources that can help them provide one. Over the past 15 years, I have worked, Be More for Healthy Babies has worked and collaborated with all Baltimore City birthing hospitals to implement the safe sleep education efforts outlined in this bill, namely the safe sleep education prior to postpartum discharge provided in both oral and written fashion in a variety, which can take place in a variety of formats. And indeed, as this is one part of a larger campaign to prevent these deaths did come down over the course of a decade. However, without education being required, keeping these efforts going is a constant challenge. And, hospitals in particularly are, dealing with a lot of staff turnover, and this was exacerbated during the COVID-19 pandemic. And indeed, the deaths have they've increased over the past 4 years.
It's okay. You could take a few minutes, a minute to wrap up.
Thank you. So, and it also over the last 5 years, our child fatality review team that found that no safe sleep education was documented by the birthing hospital in 57% of the deaths that occurred. So we really believe this bill will help to ensure that life-saving education happens. There's no financial outlay by the hospitals. The American Academy of Pediatrics guidelines and free educational materials based on those guidelines already exist and are readily available. And we have been fortunate enough to work very closely with our sponsor and our partners to arrive at an amended version of the bill that we believe can save lives. So I respectfully request a favorable report on House Bill 177.
Thank you, and thank you for your time today and your testimony. I'm going to open it up for questions now. Are there any questions from the committee?
Is anyone curious about the fiscal?
All right, seeing none, you must have done a great job. I see no questions. Thank you very much. So we have Shelley Shue from the Maryland Department of Health, favorable with amendment. The Maryland Hospital Association, favorable with amendment, and Pam Case-Meyer. Could you please come up, all three of you, since it's favorable with amendment? And who would like to get started? And again, thank you for your patience. I know you ladies have been waiting for a long time, so we appreciate it, okay? Department of Health would like to start?
Right.
Go ahead.
Hi, everyone. I'm Shelley Chu and I'm with the Maryland Department of Health. And thank you for the opportunity to speak today. And on behalf of the department, we are in support of HB 177 with amendments. Between 2016 and 20, Maryland experienced 222 sudden unexpected infant deaths related to unsafe sleep environments or practices. And at the department, we align our safe sleep guidance with the most recent recommendations provided by the American Academy of Pediatrics. And in those recommendations, the AAP highlights the need for comprehensive and a multi-partner approach for preventing sleep-related deaths. In 2023, the department did update our infant safe sleep resources, including updating our webpage, designing an educational one-pager, and developing a social media toolkit, all shared with partners. And the department also conducted outreach to providers, urging them to share safe sleep messaging with their patients and alerting them of these newly updated resources. And local health departments just have been consistently a resource for providing the safe sleep education and also some of the actual products like portable cribs and bassinets. The department proposes amendments to require birthing hospital staff to directly connect patients or guardians unable to provide that safe sleep environment with their local health department or a local agency that can provide those resources like a portable crib or bassinet before discharge, rather than merely providing a resource list. The department also recommends removing the requirement that parents and guardians sign a form that they have received the education prior to discharge to remove the administrative burden. And then finally propose removing the requirement to develop a new resource list, given the work that the department and local health departments have already done related to safe sleep resources. And thank you.
Thank you. Thank you for staying with the time. Appreciate it. Who's next?
Sure. Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association and our member hospitals and health systems. We're in support of House Bill 177 with Delegate Lewis's amendments. We've been working closely with the delegate and the Baltimore City Health Department on the bill. We believe the amendments achieve the important goals of the bill while allowing hospitals the flexibility to provide educational resources on safe sleep in a way that benefits the patient population that they're serving. Hospitals provide safe sleep education during the patient stay and at the time of discharge. As the delivery of patient education technology changes, it was important for us to have not be prescriptive in the approach, so that if it's an iPad or instructional video, whatever it is, it should be meet the requirement of the bill. We'd like to thank Ms. Hopwood for drafting amendments that strike that balance, again, meeting the goals of the bill without being overly prescriptive. And we appreciate the partnership of Delegate Lewis and the Baltimore City Health Department. We do think there are opportunities for us to collaborate to ensure we're providing the same safe sleep messaging across the healthcare continuum, before pregnancy, during pregnancy, and afterwards. At the hospital, you're kind of like the last stop. Hopefully that patient has heard that message over and over and over, and we're just reinforcing at that point. But as the hospital field, we are happy to be part of the solution in reducing preventable infant deaths from an unsafe sleep environment. So we ask for a favorable report on this bill with the sponsor's amendments. Thank you.
And thank you for working with a sponsor and with Ms. Hopwood. We really appreciate it. Next, please.
Hi, Madam Chair, members of the committee. I'm Pam Casemeyer here on behalf of the Maryland chapter of the American Academy of Pediatrics. You've heard their name already several times during this hearing, and I'll save you a little time. We've been working with the sponsor and the City Health Department and MHA and others on all of these amendments, which we know you'll deal with in subcommittee. All I can say is you've heard this has been a priority for the Academy of Pediatrics for a very long time. And it's a very significant issue with a fairly simple approach to being able to make sure we address it. And with that, I'll say thank you.
Thank you very much for working together with the sponsor. Good job. I'm going to open it up for questions now. Are there any questions for this bill? Seeing none, thank you very much. This is going to be assigned to the subcommittee. So if you can please come, all of you, and work with the subcommittee. This actually concludes the bill hearing on House Bill 177. We're now on the last bill of the day, House Bill 97, Baby Food Toxic Heavy Metals Testing and Labeling. I want to take a minute to thank the people that are waiting on this bill that are about to testify for your patience, right? We started late today because of the state of the state. But you know, it's close to 6, not bad. And whoever can get started, that will be wonderful. I believe that you have, if you could bring your panel, Delegate Taveras. Delegate Taveras, can you bring your panel, please? Okay.
Thank you, everyone. Thank you. Thank you, Madam Chair.
You're welcome.
So
this is your first testimony in front of us, correct? Oh, no, you
No.
went before last year?
I did.
Oh, you were gonna be
I'm the
asked a lot of
massage
questions.
queen, remember? I'm the massage queen. Don't forget.
Okay,
So no, I know the game.
all right, let's do it, play it.
So thank you, Madam Chair and committee members. So, okay, scene. All right. As always, it is an honor to be before you. I'm here to ask for your favorable report on HB 97, Rudy's Law, Toxic Heavy Metals Testing and Labeling. This is a really serious issue that we have here today before us. This bill addresses the presence of arsenic, cadmium, lead, and mercury in manufactured baby food sold in the state of Maryland, exhibited like products that are right here before you that we just bought last night. And products like this that I was drinking as of last week until I was investigating this legislation. Our bill mirrors California's bill with regards to when the baby food is tested to address supply chain concerns raised by the Maryland Retailers Association. Manufacturers shall report results to the Department of Health upon request. And additionally, companies will be required to include the test results in their website and include a QR code on their baby food label that directs consumers to the test results. However, we must disincentivize the selling of poisoned baby food to our children. As such, should a baby food product be found with elevated heavy metals, a manufacturer shall be fined per product. So in 2020, the Clean Label Project found that 95% of baby food had elevated traces of these heavy metals, failing to meet the Food and Drug Administration guidelines. In 2021, a subsequent investigation found that popular brands had up to 91 times more arsenic, 117 times more lead, like this product right here, parts per billion, and 69 times more cadmium than recommended doses by the FDA. These findings sparked a congressional hearing that recommended that, can I finish?
No,
Thank-
you can go ahead. You're not time.
Oh, thank you.
Okay.
A congressional hearing that recommended that baby food be tested for toxic elements. HB 97 is being presented to ensure that this testing is done and consumer transparency exists. As of November 2023, nearly 40% of conventional baby food products analyzed in a new US study found toxic pesticides. Well, sorry, given the low body, sorry, this was a change on that. Given the low body weight of babies, it makes it easier to absorb these heavy metals. Such exposure in early childhood is linked to serious health issues, including developmental disorders such as neurocognitive impairments, growth disorders, organ and bone disease, and cancer. This situation is further exacerbated by the slow pace of federal action. FDA will provide a draft guidance this year and finalize it in 2025. No guidance in mercury has begun. Arsenic has been established. And Maryland therefore is at a crucial role to play in safeguarding the health of infants now. So I humbly ask for your favorable recommendation on HB 97. Our children's lives are at risk.
Thank you.
And if you would allow, this is a bill as amended, and we've just received the amendment like a few minutes ago.
Okay, and the amendment came from where?
The bill drafting office.
No, but who, is it the industry? Okay.
No, we put it in on behalf of the industry.
All right, when they come up, I'll ask them. Who will you like to testify next, please?
Okay, I would like Ms. Callahan to please speak, then Dr. Michaels, Dr. Peters, Susan Hume, and Eric Lopez.
Okay.
In that order.
Good afternoon.
Good evening. Thank you, Chair Pena Melnick and committee members. I am here to ask for your favorable report on HB 97, Rudy's Law, Toxic Heavy Metals and Testing and Labeling. My name is Sarah Callahan. I'm a lifelong resident of Maryland and Rudy's mom. Rudy, the reason my family and I are here today, was born a healthy baby in 2022. In May of 2023, we introduced Rudy to food purees to begin his transition to solid foods, and he loved eating the Wanabana apple cinnamon fruit puree pouches. In August 2023, Rudy had his blood level tested as part of his 1-year checkup. We were alarmed when the health department called us with his high results. Our doctor recommended the EPA's lead-safe diet, and we stopped Rudy from consuming the puree pouches to focus on eating whole foods rich in iron. We closely monitored Rudy's blood lead levels while also working to identify the source of his lead poisoning. The Maryland Department of the Environment conducted extensive testing of our home. We tested our lead levels, and Rudy's abdomen was x-rayed to see if he had swallowed something containing lead, but every test was negative. By mid-September, we started to see Rudy's levels begin to decrease. In October, the FDA issued the Wanabana recall, and I searched our home and found one remaining pouch, this one here, and it was a match to the one of the recalled lot numbers. After more than 2 months of living in a state of uncertainty, we finally were able to identify the source of Rudy's exposure. Rudy's lead poisoning has carried many feelings: shock, anger, outrage, guilt, frustration, fear, worry, and uncertainty about Rudy's future. As a parent, your instinct is to always protect your child and keep them safe. Because we could not initially identify the source of his lead poisoning, we did not even feel safe in our own home. To help Rudy as much as possible.
Take your time and wrap it up.
Thank you. To help Rudy as much as possible, we enrolled him in the Calvert County Infants and Toddlers program and got him into the lead treatment program at Mount Washington Pediatric Hospital. To date, Rudy has been diagnosed with a speech delay. The scariest part of his lead poisoning is that he might start missing milestones and experience delayed or stalled development at any point. With knowledge, lead poisoning is completely preventable. HB 97, Rudy's Law, would help other Maryland families avoid a similar fate and allow for parents to quickly scan a QR code to make informed decisions when selecting the best baby food for their young child. In closing, as such, I ask this esteemed committee for your favorable report on HB 97. Thank you.
Thank you for being here, and on behalf of the committee, I'm sorry that your family has had to experience, what you're going through, okay?
Thank
And
you.
thank you for being here, and thank you for being patient too.
You're
It's been
welcome.
a long afternoon. Next, please.
Thank you, Chairman Melnick. I'm Dr. Michael Ikniowski, and I'm representing the Maryland chapter of the American Academy of Pediatrics and speaking on behalf of Maryland's children like Rudy. Arsenic, cadmium, lead, and mercury have recently been found at concerning levels in a variety of baby foods. Contaminated apple cinnamon products, as in Rudy's case, were responsible for widespread lead poisoning last year. At least 43 states have found similar cases of elevated lead in children. House of Representatives' investigation in 2021 recommended mandatory testing of baby food products for these heavy metals and reporting of the results on food labels. The FDA has yet to complete these recommendations. Infants and young children are particularly susceptible to the toxic effects of heavy metal. Their brains and internal organs are growing and developing rapidly, and substances that interfere with this growth and development can have lifelong impacts. Children eat and drink more relative to their body weight than adults, and contaminants in their food and water will have greater impacts on their smaller bodies. Chronic exposure to arsenic can affect cognitive development in children. It's been associated with increased risk of infection, liver dysfunction, skin disorders, and bone marrow suppression. Exposure also increases the risk for lung, bladder, and skin cancers. Cadmium has been linked to lower children's IQ scores, an increased risk of learning disabilities, and increased needs for special education services. Toxic effects of lead include lower IQ scores, decreased academic achievement, language difficulties, attention problems, and behavior disorders. Childhood lead poisoning affects persist into adulthood with increased risks of cardiovascular disease, cancer, early onset dementia, and mental illness. Inorganic mercury can cause acute poisoning and can damage the kidneys and the lining of the GI tract. Organic methylmercury is a potent neurotoxin associated with adverse neurodevelopmental effects after in utero exposure. The optimal solution to heavy metal poisoning in children is preventing exposure. House Bill 97 takes steps to ensure the safety of the foods for infants and toddlers by requiring testing and reporting for heavy metals in these foods. It's critical to minimizing exposure to these toxic effects. The Maryland AAP requests a favorable report on this bill. Thank you for your time.
Thank you for your time and for your patience today. Next, please.
Chair Peña-Melnick, thank you. Committee members, thank you for allowing me to speak favorably on HB 97. My name is Eric Lopez. I'm a resident of Maryland and a father to a 1.5-year-old daughter. My little one was born at the University of Maryland and came to this world with significant health issues. When my wife and I were preparing for the new addition to our family, our first and only child so far, we wanted to make sure that every decision we made was in the best interest of our daughter's health. She has special medical needs, and we felt a heightened sense of wanting to protect her. By her first birthday, she had had 3 major surgeries and had 2 brain MRIs under full sedation. So this was an urgent concern of ours. In 2022, the year our daughter was born, there was a national recall of baby formula. One of the major producers of baby formula had recalled their products due to bacterial contamination in the production process, which led to severe illness and infant fatalities. We were in shock and disbelief that the very products created to nourish our children and our infants was the cause of so much harm and the fatalities. We felt like a choice was taken away from us related to something as basic and critical as food options for our daughter. We have stayed away from all baby formula because we simply could not trust the products on the market. We wish that there had been stronger regulations and laws in place back then to prevent the contamination, which, by the way, caused a national scarcity of formula. And we saw the impact of that scarcity play out with our friends who still relied on that to nourish their children. As a resident of Maryland, I want to convey my support for HB 97 and strongly urge the Health and Government Operations Committee to issue a favorable vote. Passing this critical bill will take a substantial step in holding manufacturers accountable for their products, and it will help inform parents to make the best choice possible for their children. Let's keep toxins out of the infant products altogether, but until then, the least we can do as parents is know what toxins lie within those products on the shelf. Thank you.
And thank you so much, Mr. Lopez, for sharing your story with the committee. We really appreciate it. You
Thank you,
do
Chair.
have someone else virtually that belongs to your panel. Let us go to that person and then we'll come up back. We'll open it up for questions. Will you be so kind and please bring the person in? Let me know when they're in, please. Thank you.
We got two.
Are they in?
We've got two people.
1 second, please. Bring them both in. Suzanne and then Terry Peters. Thank you. Thank you for your patience. It's technology, right? They're in. Good afternoon. Can you hear me? Terry Peters? Suzanne?
Can you hear me?
Yes, we can hear you. Thank you for your
Wonderful.
patience today.
Oh yeah, I literally was praying that you all wouldn't bring me up while I was driving from my other job. Well, I'm
We're all
ready.
ears.
All right, I am ready. Chair Jocelyn Pena Melnick and the Health and Government Operations Committee. My name is Terry Peters, and I am co-founder and owner, along with my husband, Roderick Peters, of Quality of Life Pharmacy and Health Incorporated. Our specialty is custom compounding from raw FDA-approved ingredients for the specific needs of our patients through a triad relationship between patient, physician, and pharmacist. I just want to say that toxic heavy metals, mercury, lead, arsenic, and cadmium, though found in many foods across the food chain, can wreak havoc on the systems of the most vulnerable, particularly infants whose systems are developing. These toxic metals are known to damage the nervous system, increase the risk of cancer, damage the digestive system, including the liver and the kidneys. Labeling baby food with warnings is imperative. However, a holistic approach is warranted since additive effects from contaminated water used to prepare formulas may add an additional layer of increased contamination. Testing for exposure and treatment must also be considered. Parents are justified in their concerns because the last thing that a parent should be concerned with is the possibility of poisoning their child with foods that are supposed to be providing nutrition for growth and development. In my practice as a compounding pharmacist, I have worked with families whose children have experienced the impact of being exposed to heavy metal toxicity. And working with the patient's pediatrician, I had to custom compound medications to chelate these metals and clean up their systems with wonderful outcomes. In conclusion, I support Rudy's Law wholeheartedly. Prevention, education, testing, and treatment options cannot be ignored. The healthcare team must work collaboratively to ensure that once this bill is passed, efforts are made to reduce this risk.
It's okay, you can finish.
Okay, thank you so much. To reduce this risk to our babies and communities at large. And lastly, thank you for giving me the opportunity to testify on behalf of HB 97, Baby Food, Toxic Heavy Metals, Testing and Labeling, Rudy's Law. Thank you so much.
Thank you for your patience, because I know you waited a long time. Next, please. Can you unmute her? Yes, ma'am. You're next. Can you give us your testimony? Thank you.
Good evening. My name is Suzanne Hume, and I'm the Educational Director and founder of CleanEarthForKids.org. We work to protect children's health and future on a local, state, national, and international level. Please pass HB 0097. Maryland's children must be protected from lead, mercury, cadmium, and arsenic for their health, development, learning, and future. 95% of tested store-bought baby foods contained high levels of these 4 toxic metals. There is no safe level of lead. Lead can permanently harm children's brains and nervous system, slow growth and development, and cause serious problems with speech, hearing, behavior, and increase aggression. Mercury is a neurotoxin and even in small amounts can harm children's development, Cadmium, a carcinogen, can cause problems with processing, memory, and development, even at low levels. And arsenic exposure can lower IQ, impair brain development, and cause problems with learning, memory, motion, and compromise the immune system. CleanEarthForKids.org asks you to protect the children of Maryland, and Maryland has a rich history of stepping up to stop toxics and protect health. For example, in 2020, Maryland did not wait for the federal government to protect children from toxic flame retardants in upholstered furniture, children's products, and mattress foam. Maryland passed SB 0447. And in 2021, Maryland passed HB 643 to ban 24 toxic chemicals and heavy metals from cosmetics. And now, with HB 0097, Maryland can join California in leading the nation in transparency and protecting baby food. This cannot wait. Children must be protected from lead, mercury, cadmium, and arsenic. Please pass HB 0097. Thank you so much from CleanEarthForKids.org.
Thank you for being patient and waiting. We're going to open it up for questions now. I see Delegate Kaiser.
Thank you, Madam Chair.
Pleasure.
Delegate Taveras, and maybe someone else can answer it. I just wasn't sure I heard it. Clearly, we shouldn't be selling these things. Why are they being produced at all? Why are they in any of our stores? Why are they around even nationally? And so I missed that piece. If you could.
It's
fill in those
naturally
blanks.
occurring in the soil as they're growing the product and in the wastewater of the rice that's put into the cereal. So when they're irrigating the rice, it's part of the process. And I think that we've just kind of discovered it. There's been very slow movement in 2019. Nothing was done when the federal government was informed, and slowly but surely since 2021, there've been some minor steps to address it. So there's some guidance already issued on arsenic, on lead and cadmium. That's the draft guidance out of the FDA is being proposed this year and supposed to be finalized next year. And then mercury hasn't even begun. But the issue is that kids eat every single day, 3 times a day, and maybe more, right? So we gotta make sure, as we all know, how do we keep, and at the end of the day, these elevated levels are still being found, right, in these babies' foods all across, because right now, not even a prohibition, they've just said, oh, we've got a test per the close to zero recommendation that came out of Congress. And that's what came out in California. The amendment we're proposing basically says, okay, we can test it. We could see the data, but we're going to prohibit it from being sold in Maryland. And should it be sold in Maryland, we're going to fine you up to $50,000 per product if it's found to be a repetitive issue.
If I may,
One second.
The first 30 seconds answered my question. I guess the other part was just more testimony. I just was trying to understand why it wasn't happening across the country. So I think you answered that. Thank you, Madam Chair.
All right, thank you. So we have the reason we just do like one person, right? The one question, otherwise, so we don't go spend all night. But maybe someone else can have a follow-up, but the question was answered. So let me give an opportunity to one other of my members, Delegate Shalega.
Thank you, Madam Chair. I just wanted to tell you, little Rudy is adorable and he is so well behaved. I've been watching him over here and you are a blessed mama and papa. He is a good kid. Isn't that so?
Yes.
Thank you so much.
It is so. Very patient, and we appreciate it. Any other question for this panel? I don't see any, and I just want to thank the sponsor for working with the industry. And I'm going to call the next panels, okay? Thank you so much.
Everybody.
Oh, you have a question? I didn't see your light.
It wasn't up until she
Okay.
came back on. I just wanted to ask Dr. Peters, where's your pharmacy located? You're muted.
Okay, how about, can you hear me now?
Yes.
Yes.
I'm at 8900 Edgeworth Drive, Unit G, Capitol Heights, Maryland, 20743.
Thank you. That's just a
And
shameless
and
plug.
Dr. Peters, what she really wanted to ask was, are you in my district? That's really the question she wanted to ask, okay?
Good seeing you, Dr. Peters.
But that's okay. The answer is yes. Okay, so
That's
thank you so much for being with us. We appreciate you. I'm going to call next Kaylee Locklear and also Gregory Costa. Will you be so kind and come up? Gregory is virtual. Can you bring Gregory up, please? Thank you. And thank you so much for being patient. We appreciate it.
Good evening, Madam Chair and honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Retailers Alliance. Yes, I am signed up in opposition to the bill as currently drafted. This is going to be deja vu, I think, from last night, right? I just do want to open and to address what Delegate Kaiser said with the fact that we recognize that the problem of these metals potentially being present in food is a problem, but we want to make sure that the committee understands that our manufacturers and our stores are not intentionally putting these metals in food and we are not intentionally selling them. So I just wanted to put that out there. They're naturally occurring. You heard that earlier. As a touch of background, California spent last year's legislative session refining a proposal very similar to HB 97. But this bill differed from California law, and that was our problem. So we did yesterday, got a phone call from Delegate Taveras, had a conversation last night. Hopefully the committee agrees to conform the bill to the testing standards that's in California law. That's what we asked for. That's the amendment that will come before the committee. We're asking you to support that. And that's all I have to say. So I'm glad to answer any questions about the bill. Thank you so much for working with us on this. Thanks so much.
Thank you so much for working with our members. This is not the first bill that you work with us, and we're really grateful, okay?
Absolutely.
Mr. Costa, good evening, and thank you for your patience, sir. Will you get started with your testimony?
Thank you very much. Yeah, my name is Greg Costa with Consumer Brands Association. Appreciate the opportunity today. My camera just went off. I'm not sure why. Hold on.
Well, we can hear you, so it's okay. Go ahead.
You know, I have not seen the amendment and did talk briefly with the bill sponsor and had a great conversation. I wanted to stress a couple of things ahead of that. We think at this point that the bill is a little bit premature, given the ongoing active U.S. Food and Drug Administration guidance development process to establish action levels on lead, arsenic, cadmium, and mercury in food intended for babies and young children. You know, the action at the levels at which the FDA may regard a food as adulterated and subject to enhanced action, our industry applauds that work, and it is in keeping with the Biden administration's Closer to Zero action plan for reducing childhood exposure to contaminants. As Ms. Locklear said, you know, this is not intentionally added. It is a result of naturally occurring things, so we do want to see a federal process. We, you know, our members manufacture for all 50 states, and what we're mostly worried about is having to comply with the vagaries of regulatory processes from state to state. So I would not say that that this is unwelcome legislation or misguided legislation in any way. In fact, I applaud the bill sponsor and the proponents. Industry is just very concerned about doing this in a fashion that is applied across the entire country. So that continues to be our objection, but I do look forward to seeing the amendment. I think otherwise I'd like to mostly associate our comments with the Maryland Retailers Association, and thank you for your time.
Thank you for your time, sir. We're going to open it up for questions now, and I have the first one by Delegate Bagnell, followed by Delegate Woods.
Thank you, Madam Chair. And this question is for Ms. Locklear. I just want to make sure that I was clear, because I know you had to put in your testimony before you had the conversation. Is it the position of the Retailers Association that it's favorable with amendment based on amending the bill to look like the California.
I love that you asked me this because this has come up a couple times in different committees. We actually would probably just be neutral on this bill and you wouldn't see me sitting in the seat at all. So, yeah.
Delegate Woods, followed by Alston.
Yes, thank you. So
My pleasure.
from virtual testimony, I apologize, I forgot your name. I just want to be
Mr.
clear.
Costa.
Yes, thank you, Mr. Costa. Is that right?
Yes.
Thank you. I just wanted to be clear. You said that certainly this is not something that is done intentionally. My question becomes, why is it not intentional to make sure that we are testing anything that we're growing to assure that it does not bring harm to children before we put it out and produce it?
Well, I think the testing is going on now, but what the question is to what standard and what means of testing, and what the industry through Consumer Brands Association and other organizations are trying to do is to work with the U.S. Food and Drug Administration to establish and abide by those standards and means of testing, so that we have a process that's consistent across the country.
Absolutely.
Thank you. So would it be inappropriate for Maryland to take a lead in that effort?
No, thank you for the question. It's not inappropriate for Maryland to take the lead, but California thinks it's taking the lead, and obviously you can conform to California. That seems to me, from what I heard, obviously from the bill sponsor, that's where you're headed. But we have been doing this for some time, and our experience is that when this gets into regulation, New Jersey is going to follow along on this, as is New York, as is Connecticut, and these things are going to have many differences. We would like to make sure that this is handled by the Food and Drug Administration, particularly under the Biden administration and their Closer to Zero action plan. This, I think, will represent the interests of all the states and keep industry on a path to where they can conform with one standard, hopefully a standard agreed upon by the states, without having to deal with the differences, the vagaries, and the little tweaks and differences from state to state. I hope that's helpful. The bottom line is, no, there's nothing wrong with Maryland taking.
Thank you.
One final thing, Madam Chair.
Okay.
Thank you.
You're welcome.
I don't do this often. So.
I know you don't. Just like I did stuff I don't do often today, but so you can go ahead.
Thank you. So my final question is, my concern is the time length that it has taken, because it's been many years since we've been talking about making sure that baby food is healthy for our children. And so my concern is, I hear what you're saying, and I certainly respect wanting to have a generalized program that is tweaked so that everybody is seeing and hearing the same thing. But my concern is, how many lives have to be lost? How many children have to be impacted before we finally get something uniform together across the nation?
Well, that's kind of a loaded question, and I don't think there's any answer other than that there isn't an acceptable level of damage before you act. We just do think that the FDA has been acting with prejudice and with haste, and that's that's what. And we've been, I think, very confident in how they have proceeded apace with this since the advent of this information.
Thank you, Madam Chair.
Thank you. Delegate Alston.
Thank you. I would just like for both of you to reach out to my office, because I have a very similar bill that does model itself after California. And I'm glad to hear that your concern is with things that are naturally occurring in the growing process versus additives that are actually added, like red dye. So if you could reach out so we could discuss that before the bill hearing, I greatly appreciate it.
Will do.
Any other questions? Seeing none, I would like to thank you all for being patient and for waiting, because you did, and especially that beautiful baby. Also, I would encourage Mr. Costa, if you could please attend the subcommittee. While we want the federal government to take action, we know that the federal government, doesn't work as well as a lot of the state, assemblies, right? And that oftentimes the states have to take the lead because they can get it together at the federal level. So if you could please come to the subcommittee, that will be wonderful. You are invited and we want your input so that we can discuss this.
I will do my best, and I love Annapolis, and we'll certainly try to get there. And I share your frustration with the federal government. I was a federal lobbyist before doing this, and nothing moves more quickly than state capitals.
That's correct. We do the work here. So thank you so much for being with us. I hope you have a blessed evening, okay? Take good care, everyone. Thank you for your patience. To staff, thank you very much for your patience today. We really appreciate you. And for the committee, thank you everyone for hanging tightly. And Aaron, thank you for staying with us this late. Okay, and the state trooper, thank you very much for being with us. As you know, you have the 6:30 dinner.